All right. Assalamu alaikum, everyone. My name is Samra Mirza. I'm a fourth year medical student, and today I'll be covering the clinical part of CVP as a crash course for you guys, inshallah. First of all, I hope you're all doing well. I hope the year's been to a good start for you all, and I hope CVP prep is treating you well. Um, and okay, as always, these are my details. Feel free to contact me at any point if you have any questions. And for those of you who are joining me live, feel free to unmute, chat, whatever you want, whatever's comfortable for you to stop me at any point if you have any questions or any confusion. So without further ado, the way we're going to go about this pal is I'm going to be covering everything numbered from 1 to 7 live for all of you. And then radiology will be covered separately in a little recording, and it'll be uploaded all together for you guys, just so I can cover some of the basics of radiology since you guys haven't covered it before, and then ease you into the cardio side of radiology, inshallah. So starting off with peripheral vascular diseases. These are of multiple types, and obviously the most common one that we heard of is peripheral arterial disease. So, for those of you who are here live, what do you think peripheral arterial disease is?
It's when you have blockages in your peripheral vessels, which can cause side effects, and basically that's it, I
Very
guess.
fair. Yeah, that is the basic definition of it, 100%. So, as you were mentioning, it's essentially when your leg muscles are not getting enough oxygen, enough perfusion, and that's due to occlusion of the arteries that are supplying it. So, think everything below external iliac artery, everything below it, femoral, popliteal, etc. These are the ones that are getting blocked. And this is oftentimes, it's usually due to atherosclerosis. And as you know, atherosclerosis are just these chronic changes that occur in an artery. For some, it can be earlier, for some, it can be later, that are slowly narrowing the artery and eventually blocking it. And this usually occurs in the lower arteries, hence peripheral arterial disease. Now, the way it's caused, let's do a little refreshment of our knowledge, is we have something called an endothelial injury, and this can be due to a lot of things. Most of the time, it's usually due to lifestyle problems, where you're not eating the right type of food, you're having a lot of, I guess, cholesterol dense materials, not having a nice lifestyle. So these make you more prone to having an endothelial injury. And when you have that, you can have something called LDL infiltration and oxidation. So LDL are the quote unquote bad cholesterol that you should not be having too much of. And once these can infiltrate into the internal linings of your vessels here, they can oxidize and become something called foam cells. This is done through macrophages. You don't need to know too many of these details, but it's good to know the keyword foam cells, obviously, here. And these over time can form something called a plaque, and this is as you're continuing to get distributed. This plaque is slowly but surely narrowing your artery, as you can see here, and it's decreasing blood flow as is. So by this point, you're already having decreased blood flow to your lower limbs. And as this goes on, there's always the risk of this plaque at any point, as the upper lining of the plaque starts to thin, there's always a chance this plaque can rupture and there can be a thrombosis that forms. So this is where it ruptures and you have this section over here, which can essentially become fibrotic and completely just block your artery. All right, so that's how this is happening over time. And risk factors for this obviously include smoking because the oxidants inside it are making it more prone for your LDLs to get oxidized. There's diabetes. Diabetes is just that one disease that causes anything and everything. So this is obviously one of those. And that's due to the high glucose count inside your body overall that's making you more prone to having endothelial injuries. There's hypertension that's causing the endothelial injury itself, hyperlipidemia, age over 60, because over time, as your body starts to age, it's going to develop these changes, and family history of PAD, family history of hyperlipidemia, anything as such can make you more prone to it. Now, a key word for you at this point is intermittent claudication. This is known as pain in their calves as they're exerting it. So as they're walking up the stairs or as they're moving around, they start feeling pain. And an important point to note at this is it like within 10 minutes, if they start resting, it'll go away. So that's a very important sign. This can help you distinguish it from anything else. Like say someone else is having calf pain, you don't want to confuse it with DVT versus PAD. So the way you know it is it's intermittent. It can go away over time if you rest versus in DVT, it will usually worsen over time. And the pain can, even at night, they can have pain and it can worsen if they elevate their legs, because now there's even lesser blood flow. Think of gravity, it's making all the blood go further up. There's even less blood flow to your limbs. It's having ischemic changes, and that's the one that's causing the pain for you. Now, these are symptoms. These are things people can present with. These are things people complain about. Then there's signs that the doctor can notice once they're examining them. So you'll notice that there's shiny, hairless skin. So the reason it's shiny is because it's hairless, and their nails are thicker. And this is obviously due to hairless because there's not enough blood flow, so it's not triggering enough growth of hair. And thick nails because that's a common change that you have in areas of lesser blood flow. They start getting more keratosed. And obviously, when you look for distal pulses, like the dorsalis pedis, most importantly, you'll notice it's either diminished or completely gone. It can vary. In more severe cases, you can notice that when you check the temperature of their foot, it's very cold. You can notice that they're having ulcers. These are ulcers from wounds or ulcers that can form on their own that aren't recovering. So there's like poor wound healing. And you can also notice gangrenous changes. Now, a lot of the times, these ones, thick nails, cool extremity ulcers, gangrenes, these are common signs that people with diabetes can present with. So you can get a variation of cases, right? You can get 60-year-old woman who used to smoke a lot, chronic diabetic, presents with calf pain, and when you observe her leg, you'll notice that she has shiny skin, hairless, thick nails. You'll notice that there's an ulcer at one end, and so on and so forth. Now, complications of peripheral arterial disease, obviously, if at any point it thrombosed completely and it's completely blocking an artery that's supplying your lower limbs, this can cause obvious ischemia, and if it's not getting restored in time, then you can risk having amputation. Now, for some common diagnostics and how you can determine whether it's peripheral arterial disease, an important test for you guys to know is something called the ankle brachial index. The ankle brachial index is essentially you're measuring, as the name suggests, the blood pressure in the ankle and the blood pressure in the brachial artery, and you're comparing them. So it's BP of the ankle versus BP over, sorry, the brachial systolic yeah, BP. There you go. I think I kind of missed my words, or there's a question. Wasn't it 0.7? It can be. It has a range actually, so it's a good point that you mentioned. It has a range. Commonly, the one that's most commonly used is 0.9, unless this is where it becomes abnormal. And this is where you can diagnose them with peripheral arterial disease that's more severe. And obviously, there's varying changes. Ideally, it should be much above 1.4, but if it's getting lower, then you can understand that there's like slow but gradual changes that are occurring in their peripheral vessels. If the doctor's using 0.7 in the slide specifically, sure, go with that, but this is usually the most common reading for it. And this is a very, very important test. It's the main one that you can use to diagnose a patient with PAD. Other tests that they do, usually when the patient first presents, they can do a Doppler ultrasound. They can use this to just check for the dorsalis pedis immediately. If they don't notice it, they can kind of, conclude that this patient might be having some sort of peripheral vascular disease. Other tests can include CT angiography, MR angiography. Now, again, I will be going over the details of these later in the radiology section of the PAL. But just for your knowledge, a CT angiography usually involves giving the patient contrast, and you cannot always do that in patients who might have renal impairments. So anything that usually uses contrast, just remember anyone with renal impairments, it's not most suitable to give it to them. And so when you think of renal impairments, think of a patient with diabetes. Because diabetes, again, is the one disease that can cause just about anything and everything in a patient. Should probably use a different color since this is also a red slide. Moving on. When you come into management of peripheral arterial disease, obviously it depends based on severity of the condition, right? So if a patient's coming in and they have true like thrombosis, the vessel's blocked, you cannot really think of more gradual medications. You would usually think of something that's on the spot. So you do some type of procedure. You try to give them either thrombolytic agents or you try to go in and give them angioplasty. So you'll essentially open up the vessel, like how you have angioplasty for your heart, you have it for your vessels too. And if it's very extensive, like the vessel's blocked at too many points, then you'd consider even giving them a bypass surgery for the peripheral artery. So you'll just bypass the vessel. Now, again, this depends on the patient, their comorbidities, how they're holding up overall, and so on. For patients who are, a bit better, say their ankle brachial index isn't right below 0.9, where it's an emergent situation, you can obviously suggest always lifestyle changes of smoking cessation, exercise. You should probably walk around more because as you walk around more, there is collateral vessels that are being formed in your leg. So this ensures that there's at least some blood supply that's getting to your lower limbs. If you want to start them on medical therapy, so that's medications, you'd obviously give them antiplatelets, so it's less likely to cause any thrombocytic event. You give them statins to lower the LDLs if that's the cause, and you try to optimize whatever condition it is that is causing the peripheral arterial disease. If it's diabetes, then you want to work on regulating their diabetes, making sure their blood sugar is under control. If it's hypertension, then you want to manage the hypertension itself. So it varies based on the cause of the disease, essentially. Clear so far for peripheral arterial disease? Did it go too fast?
Nope. Thank you.
Yeah, it's all clear. Thank you.
All right, perfect. So with that, we're done with peripheral arterial disease. And so we come into something called acute limb ischemia. Now, this is technically, again, what I mentioned before, which is an emergent situation where the limb is not having, like, at all, like, enough oxygen supply. And there can be many causes of that. It can be thrombosis, again, as we mentioned, of a PAD plaque. It can be an embolus. An embolus is essentially, okay, this is your vessel. This is plaque that's forming, and say this is narrowing a lot, and then here, let's say there's a thrombosis right here, right? This thrombus, as blood flow is coming and there's increasing blood pressure here to bypass this, this thrombosis can break off and it can travel in the bloodstream, and this can cause an embolus. This can go get lodged say in a pulmonary artery, which we'll cover, or it can get lodged in a much smaller vessel. Say this is your leg, and then let's say this is your foot, which I'm drawing very ugly. But let's say it comes here and it's blocking the blood vessel right here. This can cause, because it's a narrow artery, this can cause acute limb ischemia. So the rest of this portion that's being supplied by the artery, it's not getting any blood, right? That's an embolus. It can be trauma, so something that caused, let's say, an immense amount of blood to leave your body, hemorrhage, or something that caused another thrombus that formed inside because there's multiple reasons for a thrombus to form. Or if someone had, let's say, a graft in place, a stent in place, and then a thrombus that formed inside the stent. Various reasons. These are reasons that can cause a limb to no longer have blood. So it has very important signs and symptoms that you should remember. You can remember them under the 6 Ps. So first of all, they'll have pain. This is ischemic pain that usually is felt. They'll have pallor, so the area that's not getting blood, it's obviously pale. It can even turn blue over time if it's not treated. It'll obviously be pulseless. They might have something called paresthesia, and a paresthesia, does anyone know what paresthesia is?
Loss of
Loss
sensation.
of sensation.
Yes, ma'am. Loss of sensation. It can also be described as burning and shooting pain. That's another version of it. Poikilothermia, so that's most likely their nails. And then paralysis. So the limb, they can't move it. Again, this is a more like chronic change that if someone's not treating the limb ischemia, then that limb, obviously, you won't be able to move it over time. Gold standard diagnosis for something like this, if you really need to do it, is something called catheter angiography, and this acts both as a diagnostic measure and a treatment measure. This is something that's very common in CVP and also in the hospitals. The diagnostic measure also oftentimes ends up just being the treatment itself. So as you're going in, as you're trying to observe whatever blockage there is, as you're going in, you're kind of also opening it up. So that's what catheter angiography does for you. Other management besides this, you want to start them on what's it called? IV heparin. This is to prevent any further blockages, any further thrombocytic changes, sorry. And you want to make sure that they're just getting enough blood. So you're doing catheter angiography. If you need to go in further and do a thrombolytic procedure where you go in, you break the embolus, you break the thrombus, you need to do that too. This is just to save the limb. If you're not able to do any of these things and you're not able to save the limb, then it can become gangrenous and obviously you'll have to amputate. That's acute limb ischemia for you. Very fun. Moving on to the last peripheral vascular disease for you, that's Raynaud's phenomenon. Now, there's two terms, right? Raynaud's phenomenon and Raynaud's disease. What is the difference?
Raynaud's phenomenon is more of something that could happen to anyone, maybe if they're cold or they have, I think, if they're predisposed to it. But then I think disease is more of like an underlying, what's it called, like symptom of a more bigger problem, I think. I don't know.
That's very correct. You're definitely in the right area 100%. And yes, disease is also very much more common in women. And that is because, as you were mentioning, it's because there is an underlying cause. And the underlying cause oftentimes ends up being something autoimmune. And autoimmune diseases overall are just a lot more common in women. So Raynaud's phenomenon slash disease is when there is vasospasm um, in the blood vessels that are supplying your digits, usually most of the time, and this can cause color changes. So as you notice here, it might turn white first of all, then reddish, and then completely bluish if it's not getting restored in time. Now, usually you can have idiopathic, which is, there's no known cause, and it'll be symmetric. It can be in both hands, and it's very mild. It won't cause, any functional problems later on, and it'll go away on its own. But if you have a secondary cause, which is what makes it Raynaud's disease, this is something that is autoimmune that's causing changes inside you. So scleroderma, SLE, we've studied these in MSI. I don't really like them, so I'm not really going to go into the depths of them, but essentially you need to know a secondary cause, something autoimmune, will present with a more severe form of the disease, and it's going to be asymmetric. You're not going to notice it in both hands, you're going to notice it in one. So that's one important distinguishing feature, and as someone mentioned, it is more common in women, and it's more severe too. Now, signs, as we mentioned, are the color changes. First of all, it's triphasic, so it can change colors from white to blue to red, and it can cause numbness in the area. Again, that's due to low blood supply there. And if it's very severe, it can cause ulcers. Now, for diagnostics of this, the main thing you do is clinical assessment. The doctor looks at them, they observe, they're like, okay, this is Raynaud's phenomenon. If you want to do, if you want to go a step further, you can do something called nail fold capillaroscopy. So you're checking the capillary blood flow in the nail, in the nail bed area. And that's if you want to determine the secondary causes, so essentially under Raynaud's diseases. And if you're, again, suspecting that it's a secondary cause and this patient hasn't been diagnosed with an autoimmune condition beforehand, you'll consider doing that autoimmune workup for them. You can, start off with ANA, RF. These are antibodies for autoimmune diseases, and then you can go further down and, go about the whole diagnostic process. What you need to know is mostly you diagnose this through clinical assessment, and again, the differences between both types. Now, for management of Raynaud's phenomenon, you obviously, the first thing you want to do is you want to avoid cold. You want to bring heat to it because heat will stimulate more blood flow to come in, and it'll relieve the vasospasm. For a smoker, obviously, first thing you do, you tell them to stop smoking. The hell? Um, you can give them medication like nifedipine first line. You can also give them these ones, which are not that important to, for you to know for Raynaud's phenomenon, but this is again for more severe cases. And sympathectomy is essentially they're cutting up some of the nerves that are supplying this area just to prevent further vasospasms. If it's something that's very severe, if it's causing functional changes, if it's something that's reoccurring and getting more severe, that's when you would consider this line. Raynaud's phenomenon, are we clear on it?
Yep.
So all that we talked about, this is arterial, right? Not venous.
Yeah, no, it can be either. It can be either. The main arterial one that we talked about is for the limbs, for here. This is peripheral arterial, which is supplying their lower limb, tiny legs, and so on. Clear?
Okay, thank you, clear.
All right. So if that's clear, just hold 1 second, and I'm gonna get you guys a nice question. Okay, I'm gonna present you with a case. I'm gonna present you with maybe 2 cases, and we'll see how you guys feel about them. So starting off with, let's see, a woman. A woman came in. She's 62 years old. She is a smoker. And she said that after walking for 200 meters, she started having this weird calf pain. And like she sat down, and in a while, it went away. What would you do? How would you approach this patient? What are some steps that you would follow? Claudication, hell yeah. What else would you do? That's the symptom that they're presenting with. All right, how would you approach this patient? What is an important test that you want to do for this patient?
The ABI,
Yes, absolutely. And let's say, what would you okay, tell me between 2 values I'm going to give you. An ABI of 0.45 versus an ABI of versus an ABI of 1.54. Which one do you think would be the most likely ABI that this woman's having?
1.54.
the first one.
The first
What?
one. Uh, fair enough. It's okay. We'll come back. Um, good,
Wait,
good.
what was the first one?
It was,
What did you say?
0.45. 0.45.
Oh, I thought you said 4.5. Okay, sorry.
Fair, very fair. I didn't know they could have an ABI of 4.5 low key, but yeah, I'm glad that it's clear. I'm glad that it's not confusing. Anything less than 0.9, absolutely. Okay, another case for you guys. a woman, she's 24 years old. She says that she has, like, her fingers keep getting cold, and they keep her fingers on her right hand keep getting cold, and they turn white, and then sometimes when she looks at them, they also turn red. What would you think that this woman has? Raynaud's disease or
Raynaud.
phenomenon?
Phenomena.
Would you want to consider doing any tests for her? We need to ask if she always has it. So think of her age group. She's 24 and she only has it in her right hand. Would you
So
consider
being a woman is predisposing enough that we can
being
do
a woman in
extra.
this age group can predispose you to having, like, 20 age groups, so on, can predispose you to having autoimmune conditions. Like, women usually present in this age group with autoimmune conditions. And it's asymmetric, as someone's mentioning. So secondary Raynaud's phenomenon, aka Raynaud's disease, is the one that's asymmetric and is usually oftentimes caused because of autoimmune conditions. So you would maybe look into testing their ANA, testing their RF, so on, for any autoimmune conditions. Hell yeah. Very nice. Are we clear on that?
Yes, perfectly clear.
All right, alhamdulillah. Yippee. So now we're going to move into deep vein thrombosis and pulmonary embolism. So I'm going to ask you guys once again, what is deep vein thrombosis, as if the name isn't clear enough?
So it's just a thrombus in the deep veins. And that's
Okay.
it. Any.
And very nice. And how does this link into pulmonary embolism?
When it breaks off, it becomes embolus and it travels to the pulmonary area.
Yes. Very nice. Yeah, it's pretty simple actually, low-key. Yeah. Um, okay. So deep vein thrombosis, what you need to know about deep vein thrombosis, as you guys have already mentioned, is essentially it's a thrombus that's forming in your veins, in your legs. And as we know, our veins, sorry, have something called semilunar valves, and they help keep blood flow moving upwards and so on. And it's very easy for a thrombus to break off, become an embolus, and travel upwards, right? Through your veins, especially. Now, the reason I'm bringing back Virtuous Triad is because it's good to know the basis of how a thrombus is forming, right? So there's three main states that can cause it. Um, I put Lightning McQueen there, by the way, because Virchow kind of reminded me of Kachow. But anyway, there's three main states that you need to think of: stasis, hypercoagulability, and endothelial damage. Now, these are some states that can predispose someone, to have a thrombus forming. Starting off with stasis. Stasis is states where they're not moving a lot, there's blood flow, and there's blood flow in their legs, and it's not moving back up in a suitable, speed. So, stasis predisposes them to having pressure on their extremities. If they're immobilized, if they're laying in bed, there's so much pressure on their lower limbs, on their calves, that this can form a thrombus. This is irritating their linings there. So think of a patient who had surgery. Think of a person who is on a plane and they're not moving much. Think of maybe even assistants who are sitting for too long. That's the kind of thing you think of that's predisposing them to having a DVT. Of hypercoagulability. Now, this is a state where um, essentially their blood is more prone to clot, and this can be due to hemophilic diseases. It can also be due to factor V changes, and it can also be due to oral contraceptives. This is a very important one, and obviously pregnancy. And pregnancy, another important thing to note is pregnancy has two things that can be predisposing them to DVT. That is stasis, because they might not be able to move that much, especially in the later trimesters, and hypercoagulability. They're just in a state, their hormones are moving up and down, so on and so forth. The last thing is endothelial damage. Now, this can be due to two reasons. It can either be inflammatory or it can be traumatic. Inflammatory is any condition that's causing it. So it can be anything autoimmune that's leading to it. It can be infectious that's leading to it. Endothelial damage can also be because of hypertension. It can be everything that we mentioned beforehand with the atherosclerotic changes that can happen. So that's the Virchow's triad for you. Moving on into DVT. DVT has a lot of risk factors, as I mentioned. Think of surgery. If a patient's in bed rest, they're not moving much, you want to get them moving at some point so they're not going to develop DVT that can later progress into PE. Trauma, pregnancy, malignancy, hormone replacement therapy, these are just different states that can uh, affect different parts of Virchow's triad for you. And then now we talk about how this patient's presenting to you, the signs and the symptoms of this, right? So first of all you'll notice is it's unilateral, it's in one limb. You'll notice it's causing a lot of swelling and they have pain. They have pain in that one limb and it's tender to touch. That's DVT for you. There's something that your doctor discussed in the slides. It's called Homan's sign. And he talked a lot about it and then eventually ended it with the fact that it's not reliable. So just go with that. It's not reliable. You don't really need to worry about Homan's sign that much. But what you need to remember is it's unilateral. There's swelling in the calf. There's pain, and that area is very warm. There's blood pooling there a bit as well. Now, for some diagnostics that you can run for DVT, you can do something called D-dimer. That's usually the one that's most likely mentioned. This is a very important biomarker that you use for DVT. Another thing you can do is compression duplex ultrasonography. This is kind of similar to Doppler ultrasound, which is you're just checking to see blood flow in the lower limbs. Now, as we mentioned in the start, a complication of DVT is pulmonary embolism. So the thrombus, it's staying there, but again, thrombus, blood's coming at it, it can break off, travel to the lungs, and block one of the pulmonary arteries, causing severe respiratory distress.
I have a question.
Of course.
It's about D-dimer. Like I remember in the lecture, they said that it's sensitive. So yeah, if you have a positive D-dimer, or maybe it was negative. I can't remember, but it's sensitive, not specific to deep vein thrombosis. So a positive D-dimer doesn't specifically like confirm deep vein thrombosis. It could be something else, but it does indicate it. Yeah, yeah. As Mike said, she's like negative D-dimer means it's definitely not DVT. Is that
Yes,
right?
you're very
Okay.
right. Yes, it can give you like a false positive too, and it's just a biomarker that you use.
Mhm.
But you obviously need to confirm when you have a patient who you think has DVT with a duplex ultrasonography, just to have a better observation down there. But D-dimer usually helps direct you in the right way, and it's the first thing that usually comes to people's mind when they think they're tackling a case of DVT.
Okay.
Of course, and thank you, Melek, for answering further. Um, okay, moving on to the management of DVT. We'll cover this and then we'll go into pulmonary embolism. What you usually do is you want to start them on low molecular weight heparin. Then you want to do direct oral anticoagulant, or you can give them warfarin. Now, the DOACs, these are the ones that are not vitamin K dependent, if I'm getting that right. And okay, the way you work about this, giving them the medication, if it's someone who had a provoked episode versus an unprovoked episode, you want to give them different treatments. If it's a provoked episode, that means you know the cause. You know what caused this. This patient, let's say he had surgery, he's on bed rest, so obviously that's why it happened. But if it's an unprovoked cause, you don't know what caused this, they are at higher risk of developing another DVT event, and then later on it can get more severe, can progress further. So the way you treat it differs. If it's if it's provoked, you can do 3 to 6 months of treatment. If it's unprovoked, you would want to do it for longer just to prevent any unlikely episodes before you finally determine the cause eventually. Another thing to note is things that can make you more prone to developing DVT is also atrial fibrillation, just because it makes you more likely to develop any fibrillatic event, and then that can also progress further into PE very likely, very easily. So you want to obviously rule out an arrhythmic cause. If you can't give them anticoagulants, you'll give them something called an inferior vena cava filter, and I'm not going to get into more details of that because it's not necessary and it's not needed. It's just one of the treatment measures you can know. Prevention for DVT, now obviously this varies based on every cause. You want to obviously get them moving. This person who's at risk of developing DVT, you want to get them moving. If it's a surgery related procedure, once they're in a better state, you want to get them moving. If it's a pregnant lady, get them moving. If you're on a flight that's like more than 10 hours long, you need to be responsible of making yourself get up and walk around. That's one thing. If you think a patient, due to hemophilic changes or hemophilic problems, can be at risk of developing DVT, you want to give them prophylactic anticoagulants just in case. And another thing they use is compression stockings. These are just some basic points to know. They're nice to know, they're good to know. I think it can come very easily as a nice MCQ, hopefully, inshallah, if your CVP final is as good as ours was. And yeah, and so now with DVT hopefully clear, inshallah, for everyone. Clear? Yes? No?
Here.
Okay. Easy. So now we'll move into pulmonary embolism, which, as someone stated, is when the thrombus breaks off, travels in your bloodstream, and reaches the lungs, causes a blockage in one of the pulmonary arteries. Now, the risk factors to develop pulmonary embolism is all of these, and again, long flights. Now, signs and symptoms of pulmonary embolism. By the way, long flights is an important one. It was stated separately from what I remember. So just like keep it in your mind all the times whenever you're reading about long flights. Anyway, back to signs and symptoms of pulmonary embolism. The patient will have sudden dyspnea. They'll have difficulty breathing. Yes, an S1Q3 T3 sign, 100%. It's a diagnostic one. They'll also have pleuritic chest pain, so that's irritated chest pain, right? Pleuritic. They'll have tachypnea, tachycardia. They're breathing fast. They're having difficulty breathing, and they're also like breathing in very fast. Their heart rate's really high. They might have hemoptysis, which is they're coughing up blood. And if it's a very like insane episode of pulmonary embolism, they might have hypotension. They might have syncope where they're fainting. These are some very important signs, and they're like key indicators. A lot of the CVP diseases are very like classic signs. You can recognize it. It's usually very easy, inshallah. Now, for some diagnostic tests, I think Rafi, mashallah, covered a lot of the ECG stuff for you guys, and that's good because I'm not really the best person for ECGs, but I will definitely cover something you need to know for pulmonary embolism, which is an S1Q3 T3 sign. What this means is essentially S1 is that on lead 1, you'll notice that the patient has an S sign. And on Q3, T3 means that on lead 3, you'll notice that the patient has a Q wave and an inverted T wave right here. This is also known as McKinnon sign. I don't know if you really need to know the name, but just S1, Q3, T3 also works. A very common thing that they'll also have is sinus tachycardia. Perfect. Very nice. And they'll also have a loud P2 sign, a loud P2 sound, sorry, and if it's again a very insane episode, their GVP, uh yeah, their jugular venous pressure might be raised, and you guys have probably learned about measuring that too, and they'll give it to you to know the right values for this as well. Why do they have a loud P2, by the way? You ask a very nice question. Let me just check 1 second. Let me check my notes. High pressure, so it results in loud closure. Essentially, okay, so normally when you have a normal S2 sound, right? A normal S2 sound is you have an A2 and a P2. An A2 is when there's aortic closure, and then the P2 is when there's pulmonic closure, and this is what gives you the S2 sounds, right? Of these specific ones. Now in PE, the reason it gets louder is because there is okay, think of this. Think of the artery, there's blockage in it, and then there's as the blood's trying to bypass that blockage, there's an increase in the pulmonary artery pressure. There's a sudden increase in it. And because of this, as it's going back and it's leading back towards the, sorry, as it's increasing down up there, the pulmonic valve in the heart itself, it's going to shut really fast. So the way we know this is the reason the valves in the heart close in the first place is when the pressure in front of it is greater than the pressure below it, right? So when there's such an increase and sudden rise in the pressure, the valve's going to close much faster and it's going to shut like really loudly. Does that kind of make sense? Okay, yay. That's the reason the P2 sound is louder, so you're gonna hear an abnormal sound essentially. This is again in more like severe cases where there's such a sudden increase in the rise in the pulmonary artery pressure that the valve starts having dysfunction too. Moving on to some diagnostics for pulmonary embolism. Again, we mentioned D-dimer. This is just to rule out it as we mentioned. There's also something called Wells-Geneva score. You don't really need to know the scoring tactics of it. Just know that Wells-Geneva is used for pulmonary embolism. For some imaging, sorry, you'll do CT pulmonary angiography, and I'll cover this in the radiology portion of the PAL, inshallah. And if you want to confirm that it's due to pulmonary hypertension, you do something called right heart catheterization, which is you go through the right atrium to view catheter over the catheter, essentially. Now, for some management for pulmonary embolism, if they're stable, you'll start giving them anticoagulants, low molecular weight heparin, and direct oral. And if it's a massive event where they're in shock, you want to do thrombolysis. You want to go in with a catheter, you want to break the embolus if it's not, sorry, the thrombus if it's not to break on its own, essentially. Alongside this, you want to give them oxygen, you want to give them fluids if their blood pressure is dropping, which is in a very severe event, and you want to give them vasopressors if they're going into shock. Is that clear?
So what's the golden diagnostic for PE?
Technically, CT pulmonary angiography. So CT angiography, that's the gold standard. The main one, the big guy.
Okay, thank you.
You're welcome. We clear?
All clear.
All right, then. If you're clear, then that means I'm gonna ask a question. Okay. A woman recently gave birth post C-section. She had a C-section essentially, and she's complaining that her leg hurts, her calf hurts, right? Now, what are some next practices that you're gonna do? What are you gonna do for this patient? She's complaining that her leg hurts post C-section. Pregnant. Not pregnant.
D-dimer.
Okay, you can do a D-dimer for sure. You can use it. What else would you do for this patient? Dorsiflexion of the foot to get it moving. Very nice. Yes. Anything else you would do for this patient? Make her walk around. That's very nice. Yes, ma'am. And you would also, yeah, and you would also, you'd also do something called, you'll just do a Doppler ultrasound as well, just to check her, what's it called? Lower dorsalis pedis pulse, just to make sure that it's not causing a full occlusion, right? If there's no pulse there, then you have something to worry about. Nice, good.
So if her leg hurts right now, does that mean she has DVT?
She could be having DVT. You would want to check for it. She could be prone to developing DVT if it's not getting resolved already, or she could be having DVT an episode right then and there. I have a question. So wouldn't we want to insert an IVC filter so it doesn't break off and cause PE? Not always. It depends on the risk of the patient. You can also just get them started on prophylactic anticoagulant therapy. Sorry, you don't want to go in with something that invasive so quickly, especially if someone's had something like a C-section already done. And you can also just do the other measures, like we said, give her dorsiflexion, make her move around if she can. Just getting some movement in her legs would help. And then prophylactic therapy, unless she's on further risk, she has blood problems, she has any other, let's say, comorbidities that can make her more likely to develop an embolism or thrombus or something that can break off if she's hypertension for some reason. That's when you would consider something more invasive. Fair? We good? Can we
Yes,
move on?
clear. Thank you.
All right. All right. So now, with that done, we'll move into hypertension. Yeah, we'll move into hypertension. So the way hypertension is categorized, it has multiple levels. Obviously, ideally, in an adult patient, the main blood pressure you would look at is something below 120 for systolic, something below 80 for diastolic. If it's between 120 to 130 for systolic, this is when you start to worry a bit because it is a bit elevated, with diastolic still being less than 80. Now, when you start classifying, is it stage 1 hypertension? Is when they have from 130 above, 130 to 140 systolic and 80 to 89 diastolic. And stage 2 is greater than 140 systolic, greater than 90 diastolic. It's pretty like systematic approach, I think. And it's easy to memorize. Just remember these values. Now, for hypertension, what you need to know is a bunch of things. First, you need to know there's multiple types. There's technically two. Multiple is kind of taking it too far, but there's two types, then subtypes. Primary, this is the one that people usually get. It's most common in the growing population as they're aging up. And it's multifactorial, so it's genetics, lifestyle. Some people have hypertension running in the family. Some people, eat junk food, not enough walking around, not enough activity. That's hypertension causing. Then secondary are due to other diseases, right? So the subtypes, first one is renal. Now with renal, you would also remind yourself of, for me, the way I usually used to do this for studying is with renal and CKD, which is chronic kidney disease. I would also remind myself of a patient with, again, diabetes. They're at risk of developing hypertension. They might already have hypertension, and they might also have CKD. So that's a very common patient that can present to you with hypertension. Besides renal causes, and you can also have endocrine causes, so they're having primary aldosteronism, which is increasing their blood pressure. They can have a tumor, they can have Cushing's. There's also vascular causes like coarctation of the aorta, which we'll get into. And then there's other stuff like drugs that are causing it, sleep apnea, so on and so forth. These are the types. Now, the time when hypertension can become an emergent situation, as also known as a crisis, is when their blood pressure is over here. As you can see, greater than 180 and greater than 120. And now this can have two things. It can either present with end organ stage damage or without end organ stage damage. Obviously, the one that presents with organ stage damage is when you have to really, really worry and intervene and try to lower it before there's organ failure. Another thing to note is some conditions people can develop from hypertension include coronary artery disease, heart failure, chronic kidney disease because of hypertension. This is separate to the reason that chronic kidney disease being the cause of hypertension. It can go both ways, and peripheral arterial disease. And yeah, most of the times hypertension is quite asymptomatic until it starts presenting with the complications of it. So some diagnostics that you can run to diagnose a patient with hypertension. First of all, you do office blood pressure, so that's in-house, and you get an average of 2 readings, 2 visits. Now, there's something called white coat or masked hypertension. Does anyone know what that is?
White
That
coat.
is when you have hypertension in the hospital, but when you get home, it's better.
I think it's. Do you mean the reverse? When they're at home, they have it higher, and then when they're in the hospital, it's lower.
No, I mean they have
That's masked.
hypertension when they see doctors, when they see lab coats.
All right,
Isn't
perfect.
it?
Yeah. Yes, yes, yes. Sorry, I think I misheard you. When they're visiting the doctor, just to re-clarify, when they're visiting the doctor and they'll have elevated blood pressure, and it can be over 130, can be 1/142, depending. And then when they're at home, it's normal. So this can just be a white coat effect, which is they're in the hospital and they get scared. And it's masked hypertension too. And so first you do so for white coat hypertension, you do something called ambulatory BP monitoring. So this is a gold standard test, which is you essentially 1 second, sorry. Yep, they're not the same. 100%, they're not the same. Mast is the reverse. Mast is that when they're at home, it's higher, and when they're in the hospital, it's lower. And ambulatory, so for both of these, mast and white coat, um, for mast and white coat, essentially what you do is something called an ambulatory blood pressure, which is you measure it, in their normal day-to-day life. You're not measuring it in the clinic, they're measuring it at home, and they're bringing back these readings to you and getting the averages of them for you. So there's two versions again, just to re-clarify because I think it got a bit confusing. Office blood pressure and ambulatory blood pressure. Clear? Okay, perfect. Just remember, ambulatory is gold standard for both this white coat and mask. It's gold standard. It's always good to remember all the gold standard tests that you have. Now, for secondary hypertension, which is, it has a separate cause, you don't really know what it is, you want to go systematically, organ by organ. If you're suspecting a renal cause, then you'll check for renal artery stenosis. That's one. If you think it's an endocrine cause, then you want to run the respective tests for those. You don't really need to know the details of these. They're just mentioned here for your reference. If you think it's a tumor, you want to do an MRI, you want to do a CT, rule those out essentially. Moving on further, just some complications again, just for your reference. If these are just organ damages that can happen with unmanaged hypertension in the heart, it can cause left ventricular hypertrophy. It can also cause heart failure. And in vessels, it makes you more prone to develop an aneurysm. It can make you develop peripheral arterial disease, as we covered initially. For the brain, it's important to know it can cause a stroke, can cause TIA. These are very, very important ones. And again, as you mentioned, kidney, CKD, and eyes, it can cause retinopathy, and this is again another thing to also remember with diabetics. They'll present with quite literally all of these. But yeah, moving on to the management of hypertension. You have a long, long list of drugs for hypertension. I'm not going to go over them in too much detail because that's a pharma lecture for you, but memorize them very, very well. For the CVP final, I wouldn't put too much pressure on knowing all the mechanisms of action, just know the general ones, but know the side effects 100% and know the ACE versus ARBs. They obviously have the cough side effect, they have angioedema side effects. These are some classic ones that you need to know, and there are very, very easy marks for you. Know the contraindications and indications for these medications, what to give to a pregnant woman versus what not to give to a pregnant woman, so on and so forth. But moving back to hypertension, for lifestyle changes, you'll think if it's needed for this patient. If they have a high BMI, if they have a poor lifestyle, if they're diabetic, you'd want to encourage weight loss. You'd encourage a DASH diet. Does anyone know what a DASH diet is?
You have a diet that is specific.
Just-
I have no idea. Oh,
Okay. So Um, a dash diet essentially. Okay, you're gonna kind of laugh at what the mnemonic stands for. It just stands for dietary approaches to stop hypertension. Um, it mostly focuses on fruits, vegetables, whole grains, and the reduced sodium. So technically, a dash of salt does work. You would recommend these diets. You'd also recommend potassium, magnesium-rich foods. You wouldn't do that for a renal patient, though that's different, and reduced sodium. This is like a DASH diet for a patient. That's what you would recommend. Physical activity, quit smoking, limit alcohol, so on and so forth. These are just some basic lifestyle changes. Sorry, this is medications. For medications, you'd give them first-line therapies are obviously ACEs and ARBs, and you can switch from ACEs to ARBs if you notice the patient developing any side effects. Thiazide diuretics, calcium channel blockers, and then second line, you move into beta blockers. Beta blockers is more commonly used in a patient with heart failure, and then that's why it's second line if the patient doesn't present with those symptoms. And if the patient is resistant to the medications that you're giving them, you want to check for any causes, such as if the medication itself isn't helping, then there must be another underlying cause. If not, you can add a medication called spironolactone, with also a heart failure medication, as you know. And yes, that is hypertension for you guys. Is that clear?
yes.
Okay, do you have any questions for hypertension at all?
There was like something that the doctor said was important, even though it's really like such a niche detail, but he was like something about cuff size. It's supposed to be like for 80% length, 40% width. And for some reason he looked at us and he was like, "Okay, so I'm gonna ask about that." And we're like, "Wait, what?" So yeah. I think it was mentioned in hypertension, so
Or measuring the blood pressure, you mean?
yeah, like the cuff size and like where you should put it and all of that.
Okay, so yeah, and mashallah, she's answering it as well, Amalek. Yeah, that's essentially this is when you're doing the actual practice of putting on the blood pressure cuff. These are just some numbers to know. They're not really that helpful when you're actually doing it in practice, but good numbers for you to know, and it's nice that you mentioned it. Essentially, what we mentioned is for the cuff size, the width of it should be 40% of your arm circumference. That's horrible writing, excuse me. And the length of it should be 80% of your arm's circumference. And with this, it should essentially cover 2/3 of the upper arm. So when you're wrapping it around your upper arm, the way it should be covering it is it should be fully covered. Um, the length and with just like it's just this is really technical. I don't see the use of this actually in your exam. He might just be messing with you guys. But essentially, what you need to know, the reason it's okay. The reason cuff size matters and all of this matters, the fitting of the actual cuff is just because you don't want to risk getting uh the wrong reading for blood pressure. You don't want to get something that's falsely low or falsely high for this patient, right? So, and then this is always important when you're measuring adult blood pressure versus pediatric blood pressure. Um, is that and also, with blood pressure, you need to know the right way to measure blood pressure. So the patient should be at rest for at least 5 minutes when you're measuring blood pressure. Their arm should be at heart level. It should be supported. He shouldn't be holding it himself. It could be rested on a table. And that's when you put the cuff. Usually the cuff comes with a line that tells you that this part should be over the brachial artery, and so on and so forth. So just know the right practices for measuring blood pressure if need. But yeah, remember these numbers if we need to. 40% 40% width for arm circumference, 80% length for arm circumference, and 2/3 of the upper arm. Yes? We clear? All right, I'm gonna assume we're clear. I'm gonna move on to acute coronary syndrome. So before I get into the clinical part of it, I'm just gonna do a nice little revision of our coronary arteries. And I'd also recommend you guys go back to them just because I'm pretty sure you guys have, because it helps you identify which side of the heart is getting affected, which leads you need to look. Oh, I think I'm muted. Just okay. Sorry, technical issues. Starting off with the anterior view of the heart. You can tell that obviously the best way to go about this, sorry if it's moving, the best way to go about this is orient yourself. So cat of the heart, that's how you know you're looking at the anterior side. Starting off right here from the aorta, the main branch you'll see from the anterior view of the heart is the right coronary artery, and it's going to be supplying the right atrium, and it's further branches of it are going to supply the right ventricle. And then if you look at the posterior view of the heart from here, so this is reverse cat, the main artery that you're going to be looking at is the left coronary artery, and that's usually responsible for supplying a lot of the intraventricular septum. So that's very important. Yeah, whatever, septum. And it's important for supplying the left ventricle too. An important artery for you to know is the LAD. Let me just erase these markings. An important artery for you to know is the LAD, which supplies 2/3 of the anterior septum, and it's right here. You'll again notice this in the posterior view of the heart mostly. So far we've covered RCA, LCA, LAD. RCA again covers right atrium, right ventricle. LCA covers left ventricle and some of the septum. LAD covers anterior side of the left ventricle and anterior 2/3 of the septum. We're still sorry, by the way, apologies. We're still at the cat. We're not at the posterior view. We're at the anterior view. This is both anterior. Apologies if I misspoke. And then these are just the same ones again. You can know the left circumflex as well because it's important. It covers the posterior ventricle and the lateral side of the heart as well. So, four main arteries: RCA, LCA, LAD, and LCX. RCA is again anterior right atrium and right ventricle. LCA is the part of the septum essentially and part of the left ventricle. LAD is anterior side of the left ventricle, and more importantly, the intraventricular septum, most of it 2/3, and LCX is for the posterior side and the lateral side on the left. And then another thing you need to know is the PAD, posterior or PAD or PDA, posterior descending artery, and it can either come from the right or it can come from the left, and sometimes it can come from both. And these are some percentages for you to know. From what I remember from our final, it did get brought up, and it's a free mark. So just remembering where the PDA, sorry, is coming from and what it's supplying. So this way you can know the actual like cause for an MI. Like you can determine which artery to go in from and treat the patient. If you think that this patient has a PDA that's coming from the right, then you'll go in from the right artery and then so on and so forth, clear it from the left, so on and so forth, and clear it. Make sense?
Yes.
Okay. Moving on to acute coronary syndrome. So acute coronary syndrome is when any of these arteries, the major ones or the minor ones that are supplying the heart, have a blockage that's causing ischemia to the heart muscles, right? The reason this happens is, as we mentioned in the start, it can be due to atherosclerotic changes that can later cause a plaque, and then that plaque can rupture and then, fibrose and thrombose and just block the artery. And it has multiple spectrums. So coronary artery disease is something that develops over time. Acute coronary syndrome can be a complication of it, where this patient's vessels have been narrowing over time, and then one of those vessels, just the plaque ruptures and it blocks it. But over time, a patient with coronary artery disease can present with stable angina. So they usually have angina on exertion, so they have pain in their chest. They can have difficulty breathing if they're exerting, but overall, they're stable. They can have unstable angina, which is they're just in pain constantly, whether at rest or not, and this ischemic pain. Now, an angina is obviously a worse sign, but it's not uh like complete ischemia. Like it's not like a vessel is completely blocked, it's just partially blocked. Here you won't notice any changes in their biomarkers, any changes in their ECGs. Or sorry, any like severe changes in their ECGs, and it's usually fine. Then we come into the two major things that we know, STEMI and NSTEMI. As the name suggests, STEMI is ST elevated MI. So on the ECG, you'll notice an ST elevation versus NSTEMI, which is you'll not notice an ST elevation. In fact, you'll notice a T wave depression or inversion. And the difference between STEMI and NSTEMI is mostly just severity. STEMI is usually more severe at the start and it can cause a lot of significant damage versus NSTEMI doesn't cause as much damage as an NSTEMI an NSTEMI doesn't cause as much damage as a STEMI at the start, but if it progresses, it can cause just as much damage. So usually you just have a better treatment window with an NSTEMI. And for both of these, you'll notice for an NSTEMI and STEMI that the troponin, which is an important biomarker of the heart muscles, it'll rise. Troponin will be very high. It's specifically, it's troponin I. You just remember that. And we'll get into more details of these as well. Some risk factors that you need to know for acute coronary syndrome. For these ones, especially, we mentioned modifiable versus non-modifiable. So non-modifiable is age. As you continue to age, you're at more risk of developing such conditions. If you're a male, you're more at risk of developing these conditions, and family history of just heart disease in general. Some modifiable risk factors are smoking, diabetes, controlling it. If a patient has hypertension, controlling that, obesity, sedentary lifestyle, chronic kidney diseases, management of secondary diseases to the best of their ability. These are somewhat modifiable. Then, oh, sorry. Sorry. Then we come into certain signs that the patient is going to present with. First of all, they'll present with chest pain, they'll present with usually the classic way they describe it is they feel like there's an elephant sitting on their chest. It's not something that's like burning or shooting. Burning pain. Does anyone know what burning pain is? Burning pain in the back. Sorry. Let me be more
Aortic
specific.
dissection.
Yes. Burning pain in the back. They feel like something's like tearing them up at the back. That's aortic dissection. That's a different kind of pain. This is just heaviness. They feel like something's sitting on their chest. They can't breathe. It can move into their neck. It can move into their arm. That's left arm, sorry. That's signs and symptoms of MI mostly, or ACS. Other symptoms they can have alongside this is they feel like they can be sweating, they might have palpitations, they might have syncope, they might faint. For people who are diabetic, they do not feel pain, but they do feel pressure. They feel difficulty breathing, but they don't feel pain specifically, and that's because of peripheral neuropathy. Moving on to some findings in the ECGs that are noted for these conditions. For a STEMI, as mentioned, as the name suggests, you'll notice an ST elevation, and for an NSTEMI, you'll notice an ST depression or a T wave inversion, but it can also just be normal early on. Again, NSTEMI is slightly less severe, better window of treatment, but again, over time it can worsen just as much. If a patient has an unstable angina, they might also present with these changes, but it's not as common and it's usually not as severe for them to present with these changes. If a patient is having posterior MI, so usually these ones, the differentiating factor is that these are occurring in the anterior portion of the heart. It's more of the LAD that could be blocked or the LCA that could be blocked. But for posterior MI, so one of the arteries in the back, usually they'll present with ST depression or any changes in the R waves. And I'm sure Rafi covered a great amount of ECGs for you, so I'm not going to confuse you with my ECG knowledge in this one. Moving on to diagnostics for these tests, your gold standard marker is going to be troponin I. And the reason for that, it's really important to know this, in my opinion. Just know the timeline of troponin, when it goes up, how long it peaks for, how long it stays risen, and then when it finally goes down. It's important to know this for troponin, and that's because you can figure out how long the episode is lasting for essentially from this. Other tests they also use is something called CKMB, and this is useful to determine in case you think the patient is having a second episode. That's what reinfarction means, essentially. A gold standard, that's gold standard marker. Then there's also a gold standard imaging type of test, and that's again angiography. So you're putting dye into you're doing angiography, putting dye into the vessels, and you're trying to see where the occlusion is. So the dye is going to travel across the arteries, and at some point you're going to notice there's a blockage. It's not moving further. That's where your um, blockage is at. Now, this is contraindicated in patients with renal impairment and a bunch of other conditions, and I'll cover that in the radiology section. And that's again because this can just further progress their CKD. Other tests that you can do besides this, obviously the basic CBC, renal profile, lipid profile, coagulation. This is just basic tests to do if you want to rule out any other cause for the ACS. And this is essentially chest X-ray. I'll get into that. It's just to identify how it looks. So you wanna exclude any other condition that could be causing these symptoms for the patient. You want to exclude heart failure. You want to exclude hypertrophy, any embolism, any aortic dissection. You want to exclude all these causes. For this, you might, like last resort, do a chest X-ray after stabilizing the patient. Moving into the further management for this. This is a really nice mnemonic to remember for STEMI treatment. It's called MONA. So you give them morphine. That's for the pain. That's the first thing you do just to help relieve the patient. You'll give them O2 if their SATs are dropping. You'll give them nitrates. This is to open up the vessel, at least temporarily in the time being, and you might give them aspirin. And this is, again, to prevent another episode from happening. So this is MONA. This is your first, rule of movement, essentially. Then you'll give them anticoagulants further, again to prevent any other episodes. Uh, and for reperfusion, if this patient presented early on, then you want to try and break the thrombus inside. So you do PCI. This is obviously within like a golden window. And if you can't do PCI because you're not in that golden window anymore, then you can look into thrombolytic agents like alteplase, tenecteplase. The reason you might not be in a golden window is the patient's destabilizing further, and you don't want to go in with an invasive procedure because that is usually the case. Alongside these treatments, you can give them any of these. You can give them beta blockers, ACEs, ARBs, antagonists, aldosterone antagonists, spironolactone. If you notice that this patient is suffering from heart failure post-MI, which can also happen. This is STEMI. Now, for NSTEMI, you'll start them on dual antiplatelet therapy. This isn't completely for the long run, it just depends on the patient's overall course. And again, if they're high risk, your plan is going to be a lot more different. You're also going to try to do an angiography just to see if they are suffering from any other diseases like triple vessel disease, which is three major arteries blocked, or if they're suffering from DAD, which is diffuse artery disease. You want to rule out any like increased severity because this again predisposes them to another episode. So you're just classifying the risk of the patient and treating them according to it. If they're at higher risk, you want to put them on longer anticoagulant therapy. You want to look into a CABG procedure for them, which is a bypass procedure if it's necessary. Versus if they're low risk, then you're just going to go conservatively. You'll do medications. You might do a stress test later on just to see how they're performing overall. Moving into some complications that you can have from this. Starting off, you can have arrhythmias. The patient can go into VFib, and that's essentially nearly a death sentence for that patient. They can go into ventricular tachycardia, they can go into bradycardia, they can go into atrioventricular block. These are recoverable. They can have valve problems, so they can have a valve rupture, they can have defects that can form, so ventricular septal defects, they can have cardiac tamponade. An important one is heart failure. So usually patients who end up having STEMI or NSTEMI, if it's not treated correctly or not in time and so on and so forth, they might end up developing heart failure, which is their ejection fraction starts going down to the strength with which their left ventricle is pumping is not very high, and this patient starts experiencing a whole other um, myriad of symptoms, which we'll get into towards the end of this PAL. And yeah, these are just some other ones to know, but the main ones you need to know are mostly this one: arrhythmias, heart failure, aneurysms, important one. And again, for preventative treatment, after assessing the risk of the patient, you'll put them on beta blockers if it's hypertension. You put them on anticoagulants if their blood profile isn't looking that nice. You'll put them on dual antiplatelet therapy if they're in line to get another procedure like angioplasty. If you notice this patient has severe blockages, you'll do a proper angioplasty procedure given the stability of the patient. And I think with that, I have covered acute coronary syndrome for you. A lot of clinical is just kind of like common sense for CVP, if that makes sense. And it's quite simple, especially after you've covered a patho of CVP. These are just some things that go hand in hand. They're like filler information. So a lot of this is theoretical. You just listen to it and it helps, in my opinion. Does it help? I hope so. Did you guys fall asleep?
No,
I do
wait.
have a question.
Yes, go
You
ahead.
said initial DAPT for NSTEMI and unstable angina. What is
Yes,
DAPT?
dual antiplatelet therapy. So you're going to put them on two medications. You'll put them on aspirin and you'll put them on an inhibitor of this class too. It's from your pharma lecture. Let me give you a nice example. I agree. Clopidogrel, yeah. Clopidogrel, you'll give them clopidogrel. You can give them prasugrel, based on the uh possible like comorbidities they have, anything you want to prevent, sorry. So clopidogrel is the most common one that's used. It's a very good drug, and it's very potent. And there's prasugrel, which you give in patients who are trying to avoid a TIA and a stroke, and so it varies. But you'll give them aspirin essentially with any P2Y12 inhibitor.
Thank you. I appreciate it.
Of course, you're welcome. So we're clear with acute coronary syndrome. Okay. And then we'll move into congenital heart disease. Uh, this is mostly like just, yeah, it's going to be, inshallah, speed run-ish. So we're just going to go through it slowly. Congenital heart disease. The way we define this is essentially there's an abnormality that the baby or patient was born with, either in the heart itself or in the great vessel. So that's the aorta, the pulmonary trunk. These are the two major ones. Now, the reason a person can have congenital heart disease obviously start with the mother, the pregnancy. If the mother had rubella, which predisposes her to having some complications with her child. If the mother had diabetes, if the mother was exposed to any teratogens, these are some things that are affecting the development of the baby overall. Other than this, there can be chromosomal abnormalities that come with a myriad of other symptoms, and one of them can be congenital heart disease, and if it's just something that runs in the family. Right? These are some causes for it. So before we get into the diseases itself, there's two things you need to know: a left to right shunt versus a right to left shunt. In a left to right shunt, so that is between um, a left to right shunt, sorry, causes an increase in the pulmonary blood flow, which leads to pulmonary hypertension. So again, blood is moving more towards the right side of the heart. It's causing pulmonary hypertension and Eisenmenger if untreated. Versus a right to left shunt. So this is from the right side of the heart to the left side. Blood is moving with more force into the left side from the right side. So that means deoxygenated blood. This is something that's going to present with cyanosis, right? And then there's obstructive changes in the heart, and these are just things that are preventing overall flow of the blood and also increasing the pressure in the heart. So again, we have three things: left to right shunts, right to left shunts, and obstructive lesions. They present with different types of symptoms essentially. When you have pulmonary hypertension, you can also think of raised GVP over time if it's increasing in severity. Now, starting off with some congenital diseases, you'll start off with atrial septal defects and ventral septal defects. Starting with atrial septal defects, this is between the right and left atrium. Um, usually they're asymptomatic. They won't present with too many severe symptoms, and they present with something called a systolic ejection murmur. These are important to know. Know the murmurs for each defects, each diseases, free marks, easy marks. Just remember these. And some complications that you can have from atrial septal defect, pulmonary hypertension, as we mentioned, because this is a left to right shunt. You can have right ventricular failure, arrhythmia, and emboli, paradoxical emboli. So they're forming and they're forming, they're moving, they're lodging, they're coming back, forming again, so on and so forth. A gold standard test for atrial septal defect is an echocardiogram. I'll get into this test later on in the radiology section. Have faith. And the treatment for this is just closure of the valve through surgery. And again, the furthest you determine if the patient actually needs it or not. And that's who the QPQS interrupt. Sorry for the cough. Moving on into ventricular septal defect. It's one of the most common ones, and it's quite severe. It presents with a harsh, hollow systolic murmur. Very important, very characteristic. Just have it memorized. And it can close spontaneously on its own, but if it's larger, it can lead to heart failure, it can lead to pulmonary hypertension, so on. Again, for both of these, the gold standard tests are echoes, and treatment for this is, again, surgery. There's usually, unless it closes on its own, usually you do surgery. Moving on to other defects, there's something called patent ductus arteriosus. This is something that usually closes with birth, but in some cases, if it doesn't close, it can lead to something called a continuous machinery murmur. Um, and again, classic sign, just memorize it. And it's more common in patients who were either premature or they had rubella. So they can give you a question, mother had rubella, patient presents with a murmur, it was machinery murmur, sorry. What do you think this patient has? Patent ductus arteriosus. Very basic questions for these kind of topics usually in the exam, inshallah. For treatment, you can either give them indomethacin or ibuprofen if they're preterm, and hopefully this can help resolve the defect over time. Or if it's still persistent, then you do surgery or you put a device in. And then the aforementioned coarctation of aorta. This is essentially narrowing of the descending part of the aorta. So there's ascending, thoracic, descending. Near the descending end of it, it starts to narrow. What this causes is hypertension in your upper limbs, and it causes a low blood pressure in your lower limbs. And that's a classic sign for it too. So when you measure their what you do essentially is you measure blood pressure in an ideal situation, both upper limbs and both lower limbs, and you compare it, and this is just to rule it out. And the gold standard test for this, as mentioned here, you do a CT angiography or an MR angiography before you go in for repair of the aorta, and that's just so there's no further complications later down the line. Other than this, you might look into placing a stent. This is to open the narrowing essentially, right? And other surgeries to bypass and so on and so forth. Um, Moving on, there's another defect, very important, very nice. It's tetralogy of the Fallot. A tetralogy of Fallot, it presents with four main signs: a ventricular septal defect, right ventricular outflow or obstruction, overriding of the aorta, and right ventricular hypertrophy. Know these four components very well, just the four composing components of tetralogy of Fallot. It presents with something called a boot-shaped heart, and the patient also has cyanosis, clubbing, TET spells. These are essentially episodes of severe hypoxia, so they might even have syncope. A gold standard for this is an echo, and you might echocardiogram, and you might also do catheter. You put catheterize into the pulmonary artery to observe any any such changes if needed, and you might even put a stent in if there's a like blockage as such. So again, four main things to know: ventricular septal defect, right ventricular outflow or obstruction, overriding of the aorta, and right ventricular hypertrophy. And obviously, these and these are linked. Further treatment, you just do surgical repair. The patient presents it at a very early age. You really can't miss it. So they usually do it when they're in their neonatal slash pediatric age group. Then there's transposition of great arteries. So as the name suggests, what happens here is the aorta is coming from the right ventricle and the pulmonary trunk is coming from the left ventricle, and they're running, but obviously there's going to be changes in the pressure that the blood's flowing. So if the pulmonary trunk is the one that's connected to the left ventricle, so the blood's flowing out at a lower pressure overall to the lower limbs and the rest of the body, and the blood's flowing at a much higher pressure from the aorta from the right ventricle to the lungs. Um, the patient might present with cyanosis. They might also have um yeah, they present with cyanosis, sorry, and it's usually not getting better with giving them oxygen, and that's again because it's not that problem, it's a problem with the arteries itself. Moving on for the treatment, and sorry, first of all, gold standard diagnosis, echo. For a lot of these, you do an echocardiogram. Anything that involves movement, you want to observe fluid changes, you want to observe the contractility of the heart, you always do an echo. It's 3D, it shows any necessary movement, and it's gold standard for a lot of tests that require this. Versus if you want to see a structural change, you can do an X-ray. So that's what you did for tetralogy of Fallot, which is a structural change, a difference. You don't really need to see movement too much for it. Then for treatment of transposition of great arteries, you would give them prostaglandins. This is as written. It keeps the duct open, and you can also do a surgery later on down the line. You don't need to know all the details of this. Just understand the basis of the defects, essentially. You can get very basic questions from this. Transposition of great arteries, what does it involve? And it can be multiple choice, like, oh, pulmonary trunk is coming from the left ventricle versus pulmonary trunk is coming from the right ventricle. So just which of these options best describes transposition of great arteries? It can be that kind of question. I hope I was clear with that. Any questions? No? Any questions?
All clear. Thank
All right. Okay. So let's say, let me give you a small case. Um, a patient presents with a hollow systolic murmur. What defect is this? Oh, there's in the chat.
Ventricular septal defect.
Mm-hmm. Yes. Someone wrote MR, mitral regurgitation. Okay. Um, two differences, obviously. A hollow systolic murmur also does show for that, but in reference to defects like this, they'll also give you more like supporting details so you don't confuse it with with mitral regurgitation. They'll give they'll also give you a harsh it'll be a harsh hollow systolic murmur, as I mentioned, and they might also present with a thrull, which is another type of sound. Okay, another question for you guys. Um, a 2-year-old child was cyanotic, and he presented with a TET spell. So, what are some features you would notice for this child on an X-ray? One, and what are some of the composing abnormalities that this child has in their heart?
So boot-shaped heart.
Yes. And then the four changes that you notice in this.
So I don't remember.
It's fair. It's okay. Don't worry about it. Um, you'll notice a ventricular septal defect. You'll notice overwriting of the aorta. You'll notice right ventricular hypertrophy, and you'll notice right ventricular obstruction or outflow pulmonary stenosis specifically. Um, I'll just write it down again for clarity. You'll notice a pulmonary stenosis. You'll notice overwriting of the aorta. Um, VSD, ventricular septal defect, and you'll notice right ventricular hypertrophy. These four signs are very important, very easy marks, inshallah khair. Okay, I think, let me ask one more murmur actually, because these are quite important to know. Let's see. Mm, someone presents with a continuous machinery murmur. What do you think they have? Repeat the case again, the previous one? Oh, PDA, perfect. I think you meant the previous case. The previous case was just I was mentioning a cyanotic child. They presented with TET spells. What would you see on their X-ray, and what are the four abnormalities they would have? Okay, and yes, as you mentioned for this one, it's PDA. Okay, okay. Wait, last question. A teenager presents to you. He has hypertension in his upper limbs, and his femoral pulses are a bit weaker. What does this patient have?
Coarctation of aorta.
Yes, ma'am. Perfect. These are just, again, these are just the basics you need to know of them. You don't really need to know too many details. Um, Obviously, if there's any specific changes you notice in this for pathology, cover them. That's usually the one that's more heavier, but clinical is usually very easy, very straightforward. So hopefully this should be enough for you guys. Moving on into valvular heart disease. So there's usually two types of changes that you'd notice. Either there is stenosis, so there's stenosis because the flow is obstructed and there's so there's hypertension against it. There's blood is moving severely against it, or there's regurgitation, so the blood is flowing back. Right? There's these two types of overall valvular problems that you might experience. The causes for these, a lot of times it can be something rheumatic, so it's autoimmune. It can be infection based, so like any post-infectious changes in the body. It can be um post MI, so you had fibrotic changes that occurred in the valves post MI because based on the treatment of the STEMI and STEMI so on, uh with the recovery period of the heart, it'll have a lot of fibrotic changes in the muscle, so that can be one of the reasons you can have valvular problems. It can be congenital, you can be born with it. We saw a lot of congenital diseases backwards already, so one of them was tetralogy of Fallot presented with pulmonary stenosis. That's another reason. So it can have a lot of causes for it. And often the more common symptoms that a patient presents with, like their complaints, it's usually dyspnea, they have difficulty breathing, they might be tired, they might have angina, so pain, they might have palpitations, so arrhythmia, that's what you think of. They might have an emboli, so the emboli can move around, it can get lodged somewhere. So these are usually the symptoms they present with. So moving on into um, uh, mitral valve, first of all. So you can either have stenosis or regurgitation. Most important thing you need to know for these now is the cause. What's the most common cause associated with each of these valvular diseases? And you need to know the associated murmurs with them. And you need to know at a basic level just some of the managements for these, right? So starting with mitral stenosis, it's usually a rheumatic cause. What you need to know now is ignore this. This is just the pathophysiology of how this presents, what happens essentially. So left arterial pressure increases. You can have pulmonary hypertension, right ventricular failure, and then so on. You have a risk, sorry, of developing an AFib through mitral stenosis. Then, when you examine them, there'll be an opening snap. This is the important sound. It'll be an opening snap, and it'll also have a mid-diastolic rumble. These are two important descriptions for mitral stenosis. Just remember them. And again, investigations, you're looking at the movement. You want to see how the valves are. They're closing properly, opening properly, so on. So you do an echo. Anything that involves movement of the heart, you think of echo. Then you look into managements of these. You want to give them beta blockers. You want to give them diuretics. You want to give them, these are just to overall reduce their blood pressure so it's not going too high. You want to also give them anticoagulants if they're at risk of developing thrombosis, developing any such events. And obviously, if they're having mitral stenosis, they're at risk of developing atrial fibrillation leading to a thrombocytic event. You want to give them anticoagulants for that. You might also look into surgery and repair if it's very severe. So again, mitral stenosis, just remember opening snap and mid-diastolic rumble and rheumatic cause. Moving into mitral valve regurgitation, an important cause you need to remember is it can occur post MI. It can also occur like with endocarditis, and the patient can have dilated cardiomyopathy. These are just some associated conditions that present with mitral regurgitation. An important murmur that you listen to this is, as I mentioned initially, hollow systolic murmur. Again, echo, and for management, you would consider surgery most importantly if they're having any dysfunction, which a lot of the times they do end up having dysfunction. So, I hope mitral valve is clear. We'll move into the aortic valve now, stenosis regurgitation. Starting off with stenosis, usually elderly people present with it, so that's the first thing you need to know. It's usually a degenerative and progressive thing. It can happen over time, especially if a patient is presenting with, especially if a patient also has hypertension. Moving on, there important murmur for this one, crescendo, decrescendo, systolic murmur. Remember this. And for management, again, you might do valve replacement if it's causing severe dysfunction again. And then for aortic regurgitation, causes you want to look at is an important one, Marvin syndrome. You also want to look at, know also the features of Marvin syndrome. They have abnormally long limbs, if I remember correctly. Just know some of these associated signs. It can also have a rheumatic cause again, and it can also be linked with endocarditis, but important one, Marvin. For their murmurs, it has a blowing, early diastolic murmur. So just remember that. I'll be testing you on this like in 2 seconds. So just remember it. And for management, you'll give them vasodilators, and you'll give them surgery again if it's getting very severe. And before I move into this, which condition presented. Who wants to give me actually a nice summary of all the murmurs that I just mentioned? I prefer it for all of the 4 that I just mentioned right now.
I can. I'm gonna try to make it quick.
I have
Um,
you. Let's go.
okay, so the mitral valve is between the left aorta and the left ventricle, and there's stenosis and regurgitation. So stenosis is when it's blocked, regurgitation is when it's opened, and so I think there's a on examination for mitral stenosis, I think there's S1 sound that's indicative or however you say that. For mitral stenosis, opening stab with mid-systolic or mid-diastolic rumble.
Mhm,
Um, I think I think honestly that's it. Like the most important part of mitral stenosis is that the left atrium is gonna like increase in pressure since it's blocked. So it's gonna back up into the lungs and it could cause pulmonary hypertension and maybe edema or anything like that. And then mitral regurgitation, there's a holosystolic murmur. So that's very like a buzzword for mitral regurgitation. And I think it's really common. Like that's how rheumatic fever starts out. It presents with, or if it affects the valves, it presents with mitral regurgitation and later on becomes stenosed throughout, like after the progression of the disease. Then there's aortic stenosis. Um, I think I think you said aortic stenosis. You said harsh crescendo,
yeah.
decrescendo. I think it's generally just systolic murmur,
Mhm,
but more specifically that. And the most common cause of aortic stenosis is age-related, like aortic stenosis calcification. So as we
mhm.
get older, it just becomes stenosed. I think I'm not mentioning like investigations and
No,
management.
that's alright. This is more than enough, of course. Moving on,
Yeah.
aortic regurgitation, that's where you were.
Aortic regurgitation? It's also common in rheumatic fever. Like rheumatic fever, it affects aorta and the aorta and mitral valve, and it both causes like what's it called regurgitation after slowly becoming stenosed due to the fact that it's
Mhm,
like all the complications that come with it. And then there's I think an early diastolic murmur with aortic regurgitation, and it's common in Marfan syndrome just because of the like pressure buildup in the aorta, which can cause an abdominal aneurysm later on. Like that's the complication for it, I think.
mhm. Yeah,
I think that's it.
yeah, that is very nice, Michelle. Thank you so much, Nima. And yeah,
Thank
for
you.
Marvin syndrome, it's a connective tissue disorder, so it's also just problems with the heart overall, and it's fibers inside leading to um a valve problem in the aorta. And yeah, just a note, it's a blowing early diastolic murmur. They might mention that too. Just a little like characteristic word beside it. Obviously, no systolic versus diastolic murmur. They might just ask you like a very basic one, like is it a systolic murmur or a diastolic murmur? Or they might give you the buzzwords itself, crescendo, decrescendo, holosystolic, and so on and so forth. And yeah, thank you so much. Moving into infective endocarditis, all you need to know for this one is the Duke's criteria. Now, when I studied this, I did memorize the Duke's criteria. Mostly what you need to know is this, like what classifies as a fitting into the Duke's criteria. So it can be two of the majors and that's enough, or you can have one of the majors and then three of the minors. And ideally, it'd be nice if you memorize them. It's not too high, like highly important if you don't. But good to know, like what makes someone fitting into the Duke's criteria. Um, okay. Imaging is again. This is again another word for an echo, like a specific abbreviation before echo. I'll cover it in the radiology section. But again, for infective endocarditis, it's gold standard. It can help you observe any any vegetations, any abscesses, and so on. For management, you would obviously start with IV antibiotics and surgery if they're having heart failure or if this condition is progressing further and if they have large vegetations specifically. And that's what you need to know for infective endocarditis. So, okay, another thing to note, a presenting case for this could be that the patient recently got um, a new like a prosthetic valve placed in, and they're presenting with fever, and it's just this new murmur that they have. So you want to look in and see if they have any vegetations forming because of the placement of the valve. It's just like a complication of a surgery that they can have infective endocarditis from. Hopefully that's clear. And I'm gonna move into heart failure now. I was supposed to put a sad face here, so just pretend I did now. Um, Moving on. Heart failure. Essentially, it's just the inability of the heart to pump blood normally, right? Correctly. And it's either pump or fill, and it can overall just lead to low perfusion to the entire body. It can have multiple types. So it can have one where the ejection fraction is no longer maintained, so it's going below 40%. This is a systolic cause. It can have a mild version where the ejection fraction has gotten lower, but it's between 41 to 49. It's relatively controlled. And it can have one where you can have heart failure where it's really well controlled and their ejection fraction is above 50%. This is usually when it's in the diastolic part of the heart, so more of a filling problem rather than a pumping problem. Some causes. Number one cause, you would think of MI, they had an MI, they're now experiencing heart failure. It can also just, be a progression of ischemic heart disease, which is their coronary arteries are getting blocked and there's poor blood flow to the heart. There can be valvular diseases, as we learned. They can progress into heart failure. They can have cardiomyopathies, so dilated hypertrophy, and restrictive. Know the pathology images and features for these images, not that much, but features at least. They can be due to arrhythmias. AFib is always, very commonly mentioned with a lot of other conditions. It can be a complication of congenital heart disease, and again, the most important ones, this one, hypertension, um, cardiomyopathies. Moving on, like left heart failure versus right heart failure. The differences are in the presenting symptoms, right? So with right heart failure, they'll have cor pulmonale, which is the overall term used to describe it. They'll have peripheral edema. They'll have a raised they'll have raised JVP. So this is jugular jugular vein distension. Sorry. They'll have left heart failure. So left heart failure can present with difficulty breathing, orthopnea, pulmonary edema, and an S3 sound. And overall, they'll also have fatigue. They will have nocturia. They'll have exercise intolerance. They won't really be able to do a lot of movements and so on. That's just a general feature, and then know the differences between the two. Um, moving on. Moving on into the diagnostics of heart failure, you'll start with a transthoracic echo. This is again, you're observing the contractility of the heart, how it's filling up, how it's pumping. So you're going to do an echo. You'll start with the ejection fraction. This is how you'll measure it from the echo. Ideally, should be above 55%. When it starts going lower, this is when the patient is experiencing heart failure. And then there's multiple categories, as we mentioned. You'll look at the chamber size, if it's hypertrophied, if it's dilated, so on. You look at the valves, their movement, and you look at the overall pressures in each of the areas, in each of the chambers, sorry. You look at and then you look into the tissue of the heart. You want to see if it's fibrotic in any area, if there's any amyloid dispositions, sarcoid dispositions, and myocarditis, and so on. You'll also, this is just diagnostics to see if the patient is experiencing heart failure and also determining the cause for it. Then for some hemodynamics of it, you might do right heart catheterization. You might go in from the uh the inferior vena cava. You'll go in, you'll try to observe any changes, any problems in the walls, any arteries, if it's not already clear from the imaging that you have. And then you can also look into putting this patient on an LVAD or possible transplant if it's suitable for them or not. Now, an important marker that you always use for heart failure is BNP and proBNP. This is a diagnostic marker, very easy, link it to heart failure. And you also use it to determine the overall prognosis of this patient. How do you think their cases? Are they going to be fine? Do they need more therapy? Do they need an intervention surgically, or is medical therapy fine for them? This helps you at least orient you a bit. You can also do a chest X-ray, and you'll obviously do ECGs. And again, but the main test you'll do is a transthoracic echo. You'll do an echocardiogram. That's the main test for this type of stuff. Moving on, when you come into management, you'll start them Okay, an important medication to know, spironolactone, you'll definitely start them on this. You'll also give them ACEs, ARBs, beta blockers if they have hypertension that's worsening their condition. You obviously want to give them those. For patients who are experiencing right-sided heart failure, you want to give them diuretics to reduce the congestion. They're going to be having edema both in their lower limbs, and their jugular vein pressure is obviously going to go up. So you want to give them diuretics. You want to help them get rid of that extra fluid that's building up. Um, if it's a bit more controlled, you want to control their hypertension, you want to give them diuretics, and you want to give them this medication, which, if I remember correctly, this is the pagliflozin and so on, or empagliflozin. Other devices that you can consider giving them besides this is an ICD. You might also give them, you can give them an ICD, and it's not very, very important to know these. Uh, It's actually not important at all to know these. They didn't really come up in the exam, but you can have them for your reference. And yeah, you can also give them an LVAD and transplant. And the reason I'm focusing on LVAD is mostly just because of a show that I watched, but we're gonna not consider that. And you'll give them a transplant if their condition is that severe and there's a suitable donor available. Moving in, heart failure. Now, there's compensated heart failure and decompensated heart failure. A patient can have chronic heart failure and they can still have a normal day-to-day life, and then there can be a condition that's worsening their heart failure. This is when they're presenting with a lot of the symptoms. They can have JVP, like raised JVP. They can have pulmonary edema, which they normally might not have, despite being a chronic patient. They might have exercise intolerance, they're not able to move much. So this is acute decompensation of a pre-existing condition. So reasons for this could be that the patient had another acute coronary syndrome attack. They might be having a sort of arrhythmia. If they're exposed to any infection, the infection weakening them, going into their blood, so on. If they're a hypertension patient and it's not controlled for too long, that can lead to it. If they're not sticking by their provided medications, that's another reason for acute decompensation of their heart failure. So this is something that can progress into obviously more severe problems. For this, you obviously want to start off with, so you see I bolded treat precipitant. It depends on what's causing it, right? You want to start with the cause and you want to treat their symptoms accordingly. You want to give them O2, you want to give them diuretics, you want to get rid of the fluid, you want to give them vasodilators, and if they're going into shock, you give them inotropes. And okay, with that, technically, I covered heart failure, but do you guys have any questions?
Nope, thank you.
Any questions from the lecture for this? The doctor's lecture?
Nope. I think clinical is pretty straightforward, honestly.
Mhm. Yeah, I agree. I agree fully. And okay, then with that, we have technically covered clinical, and then inshallah for the radiology section, I'm going to be recording it, and you guys will have it in your PAL overall for you to refer to. I'll just inshallah be going over some of the basics for radiology, so how to read X-ray, CTs, MRIs, and then not too much detail, but just enough to get you by for CVP, inshallah. And if you guys have any questions after that, you can text me, you can message, email, whatever works. And with that, we're technically done. I would love some feedback if
Thank
you
you
have.
so much.
All right, assalamu alaikum everyone. So as promised, this is the radiology section of my PAL. I'll just be covering some of the basics of how to read a lot of the imaging modalities that are mentioned in the lecture, some of the important notes that the doctor has for your exam, and then we'll just quickly try to go over a lot of the images that we have. Inshallah, it won't be too detailed. If you do want to cover a more detailed and comprehensive view of how to, approach radiology as a whole, you can definitely go to the PAL channel. They have a lot of crash courses for radiology that your senior batches had. Otherwise, inshallah, ya Rab, this is sufficient for you. As always, feel free to reach out if you have any questions at all. I'll try my best to help you. So without further ado, the modalities that we're going to be covering are X-rays, echocardiograms, MRIs, CTs, some nuclear imaging, and then just some angiography, right? So the main thing that your doctor stressed upon in the lectures is also just some advantages, uses, and disadvantages of these modalities. I can go over them, but I would suggest you also go over them on your own and memorize them. Try to just know some of the takeaway points for each of them. Starting off with the chest X-ray, that's usually the first one people do. It's quick, it's cheap. Um, X-rays usually do tend to be cheap, but the problem is they're not very, very specific. They could be showing a myriad of problems, and they're 2D. They're usually just one view. Problems with this also is that you can't use it on pregnant women, for example, or anyone who should not be exposed to radiation at the time. And then next we have echocardiography. Echocardiography is just an ultrasound, but of the heart, right? And so this is also a first-line imaging modality. It's used when someone's presenting with a lot of cardiac symptoms, and it's portable, so that's a good. It's an ultrasound. It doesn't have any radiation. You can use it on pregnant women. The disadvantage that anything that uses ultrasound has is that it's dependent on the person who's doing the ultrasound. So, the technician should be really good at it, and also the image that you do get, sometimes you can get poor images. They might be moving too much. You might get poor windows. Windows are just like the image that you're seeing and views that you're seeing. So that's one of the other ones. So then for cardiac MRIs, MRI is a magnetic resonance imaging. Starting off, these are expensive exams. MRIs, PETs, these are quite expensive and they're long, and people also do suffer from troubles, and then people with claustrophobia might not be able to go in. People with metal implants cannot go in, sorry. And that's another one, right? But they are gold standard for volumes and tissue characterization. Memorize this very, very well. They are gold standard for volumes and tissue characterization to tell whether a tissue is fibrotic or if there's a scar here, if there's inflammation or, calcification. These are things that you can pick up easily on an MRI. And you can also use it to determine the volume inside the different chambers of the heart. Then you have CT angiography. Now, CT is a computer tomography. It's still an X-ray. It's just you're converting it from 2D into 3D, right? So same disadvantages as an X-ray, radiation, and sometimes CTs can use contrast. So this is a dye that you ingest, and it helps essentially light up on a CT. So you can see like blood vessels more clearly, for example, in areas that are highly perfused with blood vessels, right? Now, the problem with this contrast can be contraindicated in patients with renal impairment. So they can't excrete this material enough, and this can cause toxicity. So it's contraindicated in that way. You can use it to view the coronary arteries and so on. Now moving on into nuclear imaging, these are SPECT scans, PET scans, and nuclear imaging is essentially when the patient ingests a tracer material. This is a radioactive material. It goes into the areas of the heart and obviously other areas too, depending on where you're scanning. And the take-up of it, the way it's taken up by certain tissues, demonstrates the function of that tissue. You can use it to determine whether the heart's functioning properly, if the walls are taking up blood properly, they're well perfused, and you can also use it to determine if there's a tumor, for example, and there's too much uptake. And then catheter angiography, this is an invasive procedure. You use it to view the arteries. Um, You place a catheter in, you go through the veins and the vessels, the arteries, sorry. You go through the arteries, you go in fully, you have a proper view of it. It's an invasive procedure. It can be contraindicated in patients based on their stability, but it's gold for observing the coronary arteries and performing interventions. So this is, as I mentioned in the previous sections too, some tests in cardio, they're diagnostic and they're treatments too. So they can serve as both. So that's what catheter angiography is. It's diagnostic, but it can also serve as a treatment mode because, using this, you can also just place a stent in if needed. Now that's my table for this, but there's also, I hope you can see this. 1 second. Yeah, okay. There's also this table that's in your presentation slides. These are by our doctor. He's stressed on this one. I should probably use a different color, sorry. These are again the same. Okay, let's start from the first table. Well, let's not skip over it. So SPECT scans, they can help you localize areas of ischemia. As you mentioned, you can check the take-up. If there's not enough take-up in a certain place, you can tell, okay, this wall is obviously suffering from ischemia. And it's available. It's more easily available than, say, a PET. That's where it's being compared to. But the difference between SPECT and PET is PET can be used better in patients who have a higher BMI, so you can still have good visuality versus and visibility, sorry, as opposed to patients who are, undergoing SPECT scan. Maybe cannot be used in patients with obesity. With echo, the main advantage, no radiation, it's available. But the problem with echo is again body habitus, the patient's overall status. Patients who are obviously on the heavier side, it might be a bit more tougher to do an echo clearly and whatnot. And it's tough to get this correct images time and time again with echoes. Um, and again, it depends on the operator too. That's the main thing, right? With MRIs, there's no radiation. They're very expensive though, and obviously you cannot use them in cases of prosthesis, metal implants, and so on. Um, and then you have CT angiography. This is again, they're very accurate. They're good in assessment. You cannot really use them in cases of arrhythmias and irradiation. You don't want to accentuate a problem. For example, you give someone CT angio, you give them contrast, they're renally impaired. This further debilitates their renal functions. They're no longer able to excrete properly. Their electrolyte starts imbalancing. Their potassium can go up. Potassium goes up. That's risk of arrhythmia. That's usually a common cycle that's followed. So just, these are a lot of this is also just understanding based. So you can follow through with those and just understand the advantages and limitations, and inshallah it'll be enough. Then you don't need to know the numbers. These are just for you to understand the order of how things go. So based on sensitivity and specificity. The difference is obviously sensitivity is whether this test can pick up an abnormality, right? Whether it can pick up that something's wrong here. A specificity is if it can tell you where the error is, where the problem is. So CT angiography, it's really sensitive. It can pick up any problem immediately, especially if it's like a coronary syndrome. And it's quite specific too. You can see, you can visualize where you're going with it. Stress echocardiography, it's a bit lower in sensitivity. It might not always pick it up, but if it does pick it up, it's quite specific because you can uh again visualize the areas. SPECT, okay, now here's what you need to know. PET is more accurate in both sensitivity and specificity compared to SPECT. So PET above SPECT. Just know that. PET, SPECT. Remember that. Um, then you have exercise electrocardiograms, so ECGs. They're not very sensitive. They might not always pick up problems, but sometimes they can be quite specific. If they do end up picking a problem, then you can tell, okay, this lead here has a problem, and most likely this will, etc. And then coronary angiography, it's a bit lower than MR angiography is a bit lower than CT angiography. Remember that. So just remember CT angiography is more accurate than MR angiography. MPI PET is more specific than MPI SPECT, more specific and sensitive, so more accurate. And yeah, I think that's enough for knowing the differences in the modalities, knowing their limitations, and now to get into the tests, right? So starting with X-rays, because that's usually the first, one of the first few tests you do. Now, a basic way for you to read an X-ray is you do A, B, C, D, E, and you can remember it through this mnemonic. Starting with A. A is for airway. You'll check, and when you're looking at an X-ray, the first thing you'll do, you'll look at the airway. You'll check, is the trachea in the middle? Is it deviated? Is it like on one side rather than the other? Because that's just a problem, right? You'll check if the carina, the bifurcation of the bronchus, of the bronchi, is if it's at still at T4, T5 level. It's not moved down or up. That's airway. So if we come here, um, you'll see this is a normal X-ray, and this is where the trachea, it's centrally aligned. If you come lower, you can see that the bifurcation um, appears to be in the right area, around here somewhere. You can tell that, they're in the right location so far. Then you have bones and soft tissue, so B. So A was airway, B for bones now. When you look at bones, you'll look at the clavicle most likely. You'll check that the clavicles are at this angle, right? Sometimes the clavicles can be completely straightened up. Sometimes they can be way too slouchy. Sometimes you can look at x-rays. Overall, when you're looking at x-rays, you can look at the clavicles. You can check for any fractures here and there. You want to look at the right angle that they're making. Obviously, this can also vary based on the patient, like if they're moving around too much, if it's not taken at the right angle, and so on. Then you have cardiac, so C, now you're gonna look at the heart. You're gonna look at the cardiothoracic ratio. It should be less than 50%. So the space it's taking up compared the space it's taking up in the thoracic window, essentially. And then you're gonna look at the borders of the heart. Are they visible? Are they fuzzy? Fuzzy means bad, clear is good. So let's come to the heart now. You can see the heart, you can see the borders quite clearly. This is one border here, this is another border here. You can tell the other one ending here. It's not fuzzy. If it was fuzzy, it'd be like the border would kind of be like this, and that's just a problem. So you're looking at the heart, so that's C. Then D, you're looking at the diaphragm. For the diaphragm, we're going to look most importantly at the claustrophrenic and claustrophrenic angles. So that's right here. This angle should always be clear. It should always be sharp. If it's widened or if it's shortened, that suggests fluid buildup here, right? That's deep diaphragm. So essentially the words don't completely align, but they help orient you. Then E is everything else. This is just overall how you read an X-ray, regardless. And then E is everything else. Effusions, you look at the overall, like, the look of it. Do the lung fields look clear? And so on and so forth. So a little orientation again. Remember, air is always black on an X-ray. Bones are completely white. Tissues in between are going to be grayish, right? So you want to make sure that the lung fields usually look quite black. They need to look clear like this. This is a normal X-ray. Um, these are the bronchioles, etc. You can see them very clearly. Another thing to note is that you're always looking at things from a PA view, posterior anterior view. This is usually the most what's it called? Like most accurate view. It's the most used one, and it's used because it gives you more clearer images essentially. Then, moving forward, this is from your lectures. This is just a normal X-ray. You can again see the borders of the heart. They should be very clear. You shouldn't notice any like too much whiteness in the lung fields essentially. Or you know what? Let's go by a systematic approach. Let's start with the way I was telling you. So A, this is a trachea, very clear, very much not yeah, very much in the center. That's the first thing you notice. B, the clavicles, they have their nice little angle here, so we're good. C is the heart. See, it's making its clear angles. It's not taking up too much space. So you need to notice that the heart over here, like it's taking up this much space, and it's taking up this much here, and it's 50% of the overall window, you could say. A lot more from the left side, a little bit from the right side. If it was like this, and it was like this much, then you can tell that the heart is taking up way too much space. Now there's cardiomegaly here, all right? And then D, we're looking at the angles. The angles seem pretty good. And then E is everything else. You're looking for any effusions, any infiltrations, any like white patches, so on. Moving on, we're now going to come into your lecture. So, as I mentioned, you can tell, okay, the heart is here. It's already taking up more space on the left, but it's also taking up a lot more on the right too. So this is cardiomegaly. It's taking up more than 50% of the thoracic window. That's cardiomegaly. This is just from your lecture. Memorize the image. I'll remove my marking so you can see it clearly one more time. Or, yeah, there we go. Just have a nice look at it. Sometimes you just got to sit and process them, compare with normal, abnormal. Just, it'll help you remember them. Now this one over here. Now this one has cardiomegaly. You can tell it's taking up a lot more space on the left side, more than normal, and it's taking up a bit more on the right too. You can tell that the boundaries look a bit fuzzy, and that's because the overall image is a lot fuzzier. And that's because okay, see, A is clear, B is fine, C is already messed up, so cardiomegaly. D looks kind of fine, right? But now E is a problem. E, you can notice it looks very gray. Like the image should have a lot more blackness to it, right? If you compare with the normal image, which is over here, this image is clearly lacking a lot of that black space, which is from the air, and that's because something's filling up the space here, right? And that's fluid. So there's pulmonary congestion over here. That's what's going on. So memorize the image. And you should be able to, inshallah. It should be quite clear, inshallah. There's a lot of congestion in the space, and there's edema, essentially. So this patient could be presenting with heart failure for you, for example. Symptoms of heart failure, difficulty breathing, shortness of breath. Um, let's say their JVP is raised. They can give you symptoms, and they can show you this image. You can memorize it, inshallah. Now, this is an important image. It's a bat wing appearance. I'm not the best at okay, this is not what a bat wing looks like, but like you can focus on it essentially. Dear God, this is a really terrible image. I'm sorry. But yeah, bat wing appearance. And that is a clear sign of pulmonary edema. Again, also known as pulmonary congestion, but it's much more clear in this image than in the other. Here, the heart looks kind of goofy, but it's not experiencing cardiomegaly. This is because not every patient with pulmonary edema or pulmonary congestion is going to present with cardiac failure, right? But that's pulmonary edema for you, bat wing appearance. Remember this term. They might not show images all the time. They might just give you the descriptions. They'll tell you, oh, a patient came in, raised GVP, experiencing difficulty breathing. They might give you some of his lifestyle, and they might tell you that, okay, on doing a chest x-ray, he had a bat wing appearance. So that's not for you. Now this over here, let's go about it systematically. There's A, there's B, and now we're in C, but there's heart over here, but then some of its boundaries, obviously, you can't see them very clearly and they look a bit fuzzy. But then you also have this big section over here, and it's clearly an enlargement from what you usually see in an X-ray. And whenever you do feel confused, go back to a normal X-ray, and you can tell here you can see the you can see the vertebra very clearly. You can see the heart where it's starting very, very clearly. But when you come to this image over here, you can no longer see that very clear. Obviously, there's an outline, but it's not very translucent, and you can just tell there's something really wide in the mediastinal region, right? So this is mediastinal widening, as it suggests, and this is commonly seen. This image is commonly seen in an aortic aneurysm or dissection. Dissection is what can lead to an aneurysm. Dissection is, for a reference, always remember dissection presents with like searing back pain. Back pain, it's burning. Oh dear God, sorry. Tearing and burning, uh, pain in the back. And then a dissection is something that can progress into an aneurysm. It's when there's weakening in the wall of the aorta. So your blood is flowing normally, but if it starts coming here, which is the weakening in the wall, your blood vessel can become enlarged, right? And that's what the aneurysm is. So a dissection, which is like a cut in the wall essentially, is what can lead to an aneurysm too, among other things that can lead to aneurysms. Then moving on. Now, what we have here is we have cardiomegaly again, the heart's taking up too much of the window. What we additionally have is you might not want to confuse this with pulmonary congestion because yes, the lung fields do look a bit grayer, but you'll notice that on this side it's still like pretty black, but on this side it's very odd looking, and this is not similar to the congestion image that we saw over here. This is quite symmetrical all over, um, and it's like an overall like you can say a filter that was placed over it, but here it seems a bit more specific. It's a fibrotic changes. They're not that much on this side, but on this side there's not that much, but on this side there's definitely a lot more fibrotic changes, and it does look a lot more grayer than the other image. You can tell that the cost-referring angle is getting kind of goofied up too. Cardiomegaly and fibrosis. With that, we're done with X-rays. So now we're going to come into MRIs. Now MRIs, first thing you need to know, MRIs, gold standard for volumes, right? Oh, I spelled that, don't mind me. But they're gold standard for volumes, and you really, really need to remember that. That's the main thing. Now, MRIs can be T1 weighted or T2 weighted. Don't worry too much about them, just know what it looks like in each of them. So T1 weighted MRI, in T1 weighted MRI, blood will be dark. That's one. So fluids and bloods they'll be dark. Fat is going to be bright. So anything like if you consider your abdominal area, you'll notice a lot of, like brightly colored whitish grayish areas. The myocardium itself will be intermediate. It will be a mix between black and white, so grayish areas, right? How it is in an X-ray too. And then T2 weighted images, blood will still be dark, but areas of inflammation or edema, that's the main point. They'll be enhanced, so they'll become really bright instead of like fatty areas, just areas of edema and inflammation that can be from many causes, not just fat. So they'll be brighter, and you'll pick it up more through a T2 weighted image. And you have something called late gadolinium enhancement. You give them a dye, they ingest it, and then here you can now notice on the MRI, you can tell that scarred or fibrotic tissue, that's the one that's going to end up being bright and white. So again, T1, fat is bright, and T2, edema and inflammatory areas are bright, and LGE, scarry and fibrotic tissues are brighter. So now this is a normal MRI image. This is an MRI image. This is a CMR, this is cardiomagnetic resonance. Now this is giving you a cut view of the heart itself, while this is giving you a cut view, like a transverse cut of the patient's body. So you can see the heart, and you can see the vessels, and you can see the bronchioles too. So starting off, um, this is the heart over here. You can see the pulmonary trunk. You can see the bronchioles. You don't see all of them, but you can see it spreading clearly, right? And this is the heart itself for you. Uh, Atria, ventricles, you can tell. This is right. This is left. It's clearly bigger. Uh, and this is right. Okay, this is, sorry for my horrible writing. This is left ventricle for you. Remember these images. So now we're gonna move forward with them. This is again another MRI image. This is T1. This is from your lecture. This is T2. And then this is late gadolinium enhancement, and making the areas of scar and fibrosis darker. This over here is making the areas of edema and inflammation a bit more darker. And over here in T1, you can't really tell the difference that much. But in T2, again, it picks up on areas of edema and inflammation, so they appear brighter than the other remainder of the tissue. And then again, black is the area that has the blood in it. And okay, yeah. Okay. Moving on. Now we're going to come into a CMR image that's in your lecture itself. Here you can tell this area is oddly bright and it shouldn't be that bright. And this is the surrounding tissue of the heart, right? The myocardium, and it's white, and it's usually not white. It's supposed to be grayish. So if it's white, then that means there's some fibrotic changes to it. So that's what this is. This is fibrotic changes in the myocardium. There's a difference between myocarditis and endocarditis. The doctor says you don't need to know it at your level, so you don't worry about it. But you can tell here too. This is the normal lining. And this over here is brighter than the rest of the tissue. So that's what you need to understand. Something that's being picked up that's brighter than the surrounding tissue, even though it's supposed to be of similar color, that's when you know there's a problem. Another image over here. This is a cut section from the front now, coronal, and you can see the heart, and you can just tell, even if you haven't seen a normal MRI, you can just tell that the heart should not be looking like this. This is ventricular hypertrophy, and it's left ventricular hypertrophy because that's a and that's usually the ventricle you will end up seeing. So that's MRIs done. Moving on into echocardiography, right? Now, echocardiography is ultrasound, basically, of the heart. Now, you're going to have two different types of approaches that you use. You can use transesophageal versus transthoracic. Usually, transthoracic is used unless there's specific cases. Starting again, you have hyperechoic versus hypoechoic and anechoic. Hyperechoic is something that's really white on an ultrasound. So on an ultrasound, white would represent the pericardium. It could also represent any calcification, something that's gonna, something that's harder, that's dense. The myocardium itself would be grayish. It should not be too dense. It should not be calcified. Then you have, because that's the muscle itself. If that's calcified, Allah khair, And then black, you have anechoic, so that's the blood. That's where the ultrasound, if you think of the physics of it, that's where the rays are passing through, they're not being reflected too much. So again, really bright, something that's dense, grayish, medium level, black, just passing through, so it's black. Then you have a setting in it called color Doppler. This is where you can check the flow and direction of the fluid. So red and blue can vary. So if it's red, it's coming towards the probe and where you've put it, and blue is it's moving away from the probe. And then these are the normal colors you should have. But if you see a mosaic of colors, so you see yellow and green, then that means there's a problem. There's turbulent flow. It's moving back and forth when it shouldn't be moving back and forth. So that's stenosis or regurgitation. You have some views here. I don't focus too much on them. I don't think you could be tested that much on them, but for your own sake, definitely, go ahead and uh, revise these if you do. But these are just some views for your knowledge put here. And then we have, again, as I mentioned, transesophageal versus transthoracic and the difference between them and why they're used. So transesophageal is used when and I mentioned this in the earlier section too, it's used when you're thinking of endocarditis, any vegetations, when you think the patient has prosthetic valves and you want to look into infective endocarditis. So endocarditis, E, transesophageal, E. So just remember it that way. And that's usually when it's used. Otherwise, you mostly stick to transthoracic. So coming into echoes now. I'm not going to worry about the view. This is just look at it to understand how it would look for you. This is the apex. This is where you're viewing from. This is where your probe is most likely. You're going to see the left ventricle, the right ventricle, right atrium, left atrium. Again, left ventricle, just the area that looks of greater volume. That's usually the left ventricle for you. Always make sure you remember your valves. So lab rat. So left atrium. After left atrium, you have bicuspid. And after right atrium, you have tricuspid. Just remember, make sure you always remember your valves. Don't forget them at all. Moving on, this is an echo for you. And here you can clearly see there's enlargement of the left atrium, right? And yeah, that's what you need to mostly know here. There's enlargement of the left atrium on this end, and even the left ventricle looks bigger as opposed to, a normal image, which you're looking here. This is obviously a slightly different view, but it's still clearly showing that there's a problem. And there's also thinning of the wall here, a bit too much than preferred. Between the right and left atrium, just suggesting increase in size, increase in volume inside of two, maybe. Then, as we mentioned, black in an echo is fluid, it's blood. So if you have the heart over here and this is the center of the heart, so it has the blood inside it, you should not have black around the heart. Not that much. Yes, you have pericardial fluid, a little bit, but not this much. So if you have a lot of fluid building up around the heart, that's pericardial effusion. There's fluid built up there. This can lead to this can lead to cardiac tamponade, sorry. Moving on, as we mentioned, blue is for the things that are moving away from the probe, red is for ones that are coming to it. But if you see yellow and green, which you do here, this is regurgitation or stenosis valve disease. You might not always need to know the specifics, but always know it's valve disease. Moving on. This is just another image in your slides. The specificities of this are not too important, but if you get this, you can see very clearly this is a dissectional flap of the aorta. Just memorize. You don't need to worry about the technicalities of this. Just straight up memorize and move on with your day. Moving on to cardiac CTs. CTs, as we mentioned, just like X-rays, just 3D now. So on an X-ray, bone is white, fat is gray dark, myocardium, the heart, which we're going to be looking at, it's going to be grayish, air is going to be purely black. If you give them contrast, now the areas that are supplied by the blood and therefore the contrast inside it, they're going to end up being white as well. So now here's a normal CT for you. This is no contrast. Um, Blood and fluid inside it looks, like, grayish. It's not going to look white because bone is what's usually white. And, it looks fine. And you can't really identify a lot of vessels. But here now, you gave them contrast and it highlighted, made it grayish, whitish, closer to it, and it highlighted a vessel that was going here, supplying it. And this vessel ends up being the RCA. Memorize. Know that if you see this image, you know that this is the RCA, but this is what ends up being supplied here. And you can identify more clearly through the contrast that you gave. Moving on, this is again just for you to read a cardiac CT and understand the vessels that are coming through it. um Coming through the heart, sorry. This will help you at least just you might not always be able to identify which vessel you're looking at, and you don't need to worry too much about it, but you need to see how the general flow of a vessel looks as it's coming out of the heart, right? It shouldn't be interrupted. It shouldn't be like it's going and then there's a block and then it's continuing. It's clear. It's clear cut. It's moving in here. You can see the circumflex. It's dividing down. It's passing. It's passing. Like here, it's going through smoothly. There's not a block here, right? That's what you need to identify. Another image here is, again, a CT. Um, you can tell air is black. Here it's whitish, grayish. And then when you put contrast in, this is the one with the contrast. You can see the area lights up with the blood. Here, this is vessels, and you can see them supplying the tissue surrounding, and they're passing by freely. This is the image with no contrast right here. This is where the blood is, aorta specifically, right? Moving on. When you come into now, uh, by the way, the areas that are gray and they're not showing that much light, it's probably because the muscle is contracting or the cut that they have of the muscle doesn't have blood in it, so that's why it's appearing gray. But this over here, this is the aorta, and you can tell because it's bright white, because, yeah. Moving on. Okay. Okay. Now we're gonna come into images that were in your lecture. So this one, we're seeing a vessel, right? Blood, okay, this is a vessel, blood's going through, it's getting kind of thinner, blocked over here, and then it passes through. So it's like interrupted flow. So that's sclerosis of an artery. It's getting, it's getting sclerosis. I don't really know what other word I would use for it, but it's getting narrower at some regions. This ends up being the LAD, and that's what you need to know. You see this image, you think of LAD. These are the other arteries too. They are passing by quite fine, but this one over here, it's definitely of disturbed flow. Moving on. Okay, for reference, come back to the image we looked at. Here, these are the normal images. This is a normal image. And then you come to the abnormal image, which is of pulmonary embolism, and you see that, okay, these are the blood vessels supplying the pulmonary tissues, and the it's going through fine. You obviously won't see a continuous flow because it depends on the cut you're looking at, but here you can tell that there's obviously fewer lines, but you can tell that there's some thickening here and there's a clear block over here. This is a very important picture for you to know. This is of pulmonary embolism. There's a blockage in one of the pulmonary arteries coming out of the trunk. You can orient yourself. You can see here's the trunk for you. These are the arteries coming out of it, and there's a clear block here. Memorize this image very, very clearly. It is of pulmonary embolism, and it can most likely come maybe in The MCQs are on the OSPE, who knows? Um, then we were going to do CT angiography. This is just for you to get acquainted with, seeing vessels on, an angio. I'm not sure if the doctor specified specifically on, knowing all of the vessels and being able to identify them, but for your understanding, just, go through it. We're looking at the anterior view of the heart right now. So here you can see, here you can see it's the heart right now. CAT somewhere around here. RCA comes in and it's supplying the right side of the heart, the right atrium, right ventricle. You can see there's clear flow, it's not at all interrupted. Then there's the LAD, it's coming in, it's going down smoothly, no interruptions in between. You see this cut, you think of, you see an image like this of similar orientation, and you would, if you need to label, which I don't think you would, you should be able to orient yourself just a bit. You can tell from the flow at least a little bit. Usually, my batch, we used to just remember, oh, there's this nice L over here. That's for the RCA. That's how we used to remember it. Now we can come to your lecture and how you were shown it. This is a clear narrowing, clear occlusion, not fully. It's not fully blocked because the rest of the artery is still being supplied, but there's obviously a narrowing over here. Then you have the um another example here of a blockage. Obviously, it's still continuing through, there's still blood there, but here, the side where it's completely narrowed, there's a blockage in the artery, there's a narrowing. That's CT angios for you. Then we come into nuclear imaging, and we're almost at the end. You guys are so strong. We're almost there, just a little bit more to go. What you need to know for nuclear imaging is, okay, what you need to know some of these words, right? The dyes that are being used, because we mentioned nuclear imaging is using radioactive dyes that'll help light up on scans. So you see these words TC99, Tami B, tetrofosmin. These are related to a SPECT scan, and you can use these if a patient presents with something about amyloidosis. So your slides mentioned a question. And this is in your imaging and heart failure slides. At the end, you have a lot of questions. They're pretty good to go through just for nice practice on understanding when to use what type of modality. So go through them. They'll definitely help you, inshallah. And these scans, these words can be linked to such things, just buzzwords for you to remember for SPECT scan and so on. Right? So SPECT scan is used to see ischemia. You're trying to look for ischemia in the patient. Then we have PET scan. PET scan, as we mentioned, if you remember, has better accuracy in both specificity and sensitivity. You use it to look at flow. So now you have something called a rubidium PET. It uses RB82, that's a dye. It's taken up by the cells, the myocardial cells, and you can tell, okay, if there's a lot of take up, that's not good either. It should be moderate amount of take up, but if there's less take up, then that's also a problem, right? There's also stress tests. They're not the most specific or sensitive, but they're also used. And then you have other tests like FDG PET. This is mostly used to look for inflammation in the tissue. This will again look at the metabolism of the myocardial cells. It'll also look at their viability through this. If you notice any perfusion defects, that's a big one. We'll come to this. This is something your doctor highlighted too in the slides. That's overall. So we have SPECT, PET, FDG PET. Now this is an FDG PET. This is at the start, they noticed that there was, it lit up essentially over here, which is not a good sign. It was, this was an FDG PET. This was showing, as we mentioned over here, it's showing a flow over here, right? And here the flow is a bit disturbed. That's why it's lighting up like this. And then this is them giving treatment to it, and they notice that, okay, still 3 months in, there's still disturbed flow. There's still, um, an odd amount of dye uptake. This is dye uptake by the what's the word for it? The fibrotic cells. These are fibrotic changes that are occurring. So there's a lot of take up by the fibrotic side over here, and it's really lighting up. But over treatment, obviously you can't reverse it fully, but it obviously went down a bit. These are still comparatively lighter, but this over here, after treatment, it showed that, there was a decrease in uptake of the dye. Again, by the fibrotic or damaged cells. Let's not say fibrotic, let's say damaged cells. Then another one you need to look at, just remember this is an FDG PET. This is showing treatment and improvement of the tissue, decreased uptake by the damaged part of the cells over time through treatment. And this is a rubidium PET scan. What you need to know for this one is that this is representing a perfusion defect, and this is very, very important by as highlighted by your doctor. what you need to know in this image is red is showing uptake of blood, perfusion, and blue is showing low perfusion. So red is more perfusion, blue is low perfusion. So if you're looking at the heart in any of the views and you notice that um, some areas don't have the best perfusion, like over here, you can tell there's a bit of there's a bit of lack of blue at the top, a lack of red at the top, for example. So there's some perfusion defects over here versus in here too, versus here, like this is good perfusion. It's all around. That's how you look at it. Rubidium pet. Go over it again if you want to. But yeah, I didn't know that was the last much. But yeah, we're done with this, inshallah. I'm concluding my clinical crash course for cardio. Inshallah, ya Rab, it was beneficial to you. If you have any questions at any point, feel free to reach out. Um, Let me know if you have any feedback, anything specific, anything you'd like me to do differently in my pals. I'm always here for that. Um, yeah, I guess I'll come here now. Um, go over the questions, batch questions, final questions, etc. Go over practice questions that are collected by exam committee. Just, revise. Don't worry too much about the details of clinical. Again, clinical comes very easily. It's a lot more, it feels like common sense a lot of the time when you're doing it, especially after you've learned all the patho and all the, the real bulk of clinical. So the real bulk of CVP comes in patho and pharma even. So when you've learned all of those, clinical is just like, little filler details that are just connecting everything together. So it's usually very easy. Don't worry too much about it, inshallah. Um, Definitely go over your radiology pictures, especially if there's more, if there's anything I missed, go over all of them. They're definitely coming in OSPEs. If there's specific things your doctor highlighted on, additionally, definitely go over them. Um, and let me know if there's anything else I can clarify. I wish you all the best for your exams. Inshallah, they'll go very, very well. And I hope you have a lovely rest of your weekend. Assalamu alaikum.